Once again, good morning, all. Now I call upon Dr. Srinivas Jewelry, Director, Surgical Oncology, to give us a few remarks on this program. He is expertised in areas of GI and hepatopancreatoliberal oncosurgery, head and neck oncosurgery, thoracic oncosurgery, oncoplastic breast cancer surgery, laparoscopic and robotic oncosurgery, uro-oncology, CRS plus HIPEC, musculoskeletal oncosurgery, limbs lever surgery. Please welcome, sir.
Thank you, everybody. Thanks for the introduction. So before we proceed with the proceedings for the day, I just wanted to highlight a few things. Now, as we have heard just now, about 2 years back, breast cancer has taken over as the most common cancer among women in the whole world. And India was a laggard for quite some time. But in the last 2 decades, we have seen, first-hand experience, we have seen a huge exponential increase in the number of breast cancer diagnoses, exponential increase in the number of treatments that have been happening all over the country. And also, luckily, an exponential increase in the number of survivors, which probably would be the thing that we are going to celebrate today. So when WHO declared today, 19th of October, as the International Breast Cancer Awareness and they declared it as a celebratory day. Now the question is, why are we celebrating a cancer-related event? It is not celebrating breast cancer. We are celebrating life beyond breast cancer. What we are celebrating is the chance at diagnosing it, treating it, curing it, and then celebrating life as it should be celebrated. The whole issue of human endeavor is basically to be able to celebrate our lives. And towards that end, we as oncologists have come a long way for a period of time. Several decades it has taken for us to understand what biology we are looking at. Even now, a lot of things are still yet to be explored and conquered. But yes, we are halfway through, I would say. And one of the commonest ways of diagnosing breast cancer is simple self-examination. Unfortunately, the only thing that really is between breast cancer diagnosis and cure is early diagnosis. Now, there are a few things which can be avoided, prevented, and stopped from happening. But life has got its own challenges. Big majority of these cancers can't be picked up in early stages. But fortunately, breast cancer is one case study where more than 95% of breast cancers can be detected in early stages or in pre-cancerous stages. So this awareness is what we are trying to kind of give to all women in the world and all people as a corollary. So people who love their mothers, sisters, spouses, they are the ones who are supposed to take the responsibility of early diagnosis, treatment, and cure, apart from the patients themselves or people themselves. So the celebration is basically towards understanding what we are, where we are at today, and kind of having a pathway to look forwards in the future. I congratulate the team of Medicover Cancer Institute and Medicover for organizing a very informative session. I wish them good luck. Have a good day.
Thank you, sir, for stressing on early diagnosis and life beyond the treatment of breast cancer information. Now I call upon Dr. P.S. Rakesh Prabhu, a Chief Medical Officer, Medical Group of Hospitals. He has an experience of over 12 plus years in the field. Dr. Rakesh Prabhu is a passionate medico who has been driving the clinical administration domain with his excellent leadership skills, and his commitment towards the work has led to this creating a great culture of patient safety and high quality standard medical service across our hospital. He's also very passionate about medical quality care that we provide. Please welcome, sir.
Good morning, everyone. Thank you for your kind introduction. So coming to the today's topic, breast cancer awareness. So as a nursing staff, we should be more focused upon creating the awareness and reducing the cultural and emotional barriers among the female clients, which we encounter daily in our lifestyle. So when we are talking to a patient, I request you be more patient. So they have a lot of questions like, can my cancer be curable? What is my prognosis and which stage I'm in? So please listen to them. And as far as possible, restrict yourself from using the medical terminology. Talk to them in their own language and answer their queries. And as Julie sir said, celebrate the victories. When a patient is getting discharged, celebrate the victory because they have seen a lot of trauma. So give them a happy exit. Okay. I wish you all the best for this program. Once again, have a good day.
I call upon Dr. Vinod Kumar Reddy, Madhireddy sir, for giving a few words regarding breast cancer awareness program.
Sorry, I'm a little late. Got stuck in the traffic for 1 hour, so I don't blame me. Please blame the traffic. So why breast cancer prevention or breast cancer is such an important thing? If you look at the Western world, 95% of them are breast cancers are cured. The reason is it's, I wouldn't say simple, but in fact, for a patient, it is a simple disease. It's very simple. It can be picked up in screening. It can be treated very early so that you don't require chemotherapy. Sometimes if you have your breast removed completely, you don't even need radiotherapy. It's such a simple disease. But there is lack of education uh, and lack of information. For example, in Western world, the breast cancer awareness starts in their schools. So whenever, if you go to high school, so what they call is, it is called breast awareness training. So all these kids are taught how to examine their breast, like when to approach a physician if there is an issue. So these are the things. So in India, we lack those programs. So you are the best ambassadors to take these things, forward. Because now the recommendation is every woman who has crossed 40 years should get breast cancer screening. It's not just a physician examination, but they need to get in a mammogram done. So if there is a family history, your screening starts at minus 10 years. So this is the information that we want you to go and tell to the public. The whole point of breast cancer awareness is that not just to tell that, Medicover is best, we are the best. No, it's a social cause. It's everybody's cause. Because, one of my research is totally on breast cancers. Breast is called cradle of life. Without mother, there is no breast, and without breast, there is no life. But ultimately, it comes with a price, that is a breast cancer. So you guys have to make it a social cause to go out and tell people, hey, you're more than 40. Please go for screening. Doesn't matter. You don't have to come to Medicover. You can go anywhere, wherever you like. So that should be our message. But if they want to come to Medicover, yes, we are not telling no. Yeah, we are here to help you. I think we are running a free breast cancer mammogram programs. We have a free consultation. If you want, we can extend it to the close family or friends. And you guys know that we are all approachable. You can always come and ask, sir, this is a patient who is known to XYZ. We are okay. We never shout at you. We never tell you that you are interrupting inappropriately. So we are always there for you. So I think make it a great cause. And it is even more importantly, it's a social cause. More than a female cause, it is a social cause, because when mother gets affected, the whole family gets affected. So this is the message we want you to take it to the public and make this, your agenda. It's not it is your agenda. Just go tell people everybody gets a breast cancer screening. So unfortunately, government is way behind in this. So it becomes at our personal level to take the responsibility of our own health and health of our own family members. All right. Thank you so much.
Thank you, sir, for focusing on need for screening of breast cancer. Here we have Dr. Sadvik Raghuram, Senior Consultant Medical Hemo-Oncology. Now to give us an overview of breast cancer, has been awarded first in Quiz Oncology 2018. And once again, first in Quiz AMLA Oncology Breast Cancer conference. Once again, the second prize for breast oral papers. And I call upon sir to give us what is exactly breast cancer means and what we have to do on this. Please come on, sir.
Good morning, everybody. I think Juluri sir and Vinod sir have already told everything. Why is it so important about breast cancer, and why this month is celebrated as a Breast Cancer Awareness Month? So, end of the day, that is the whole agenda. That picking up the breast cancers at an early stage. So, if you pick it up at an early stage, there are multiple things. Not only the survival, but also the morbidity of treatment. These days, it is not like all a breast cancer patient needs to undergo all modalities of therapy like surgery, radiation, chemo. Now, I mean, at least in Western data, now at least 1/3 of the patients can skip all modalities. Only surgery will suffice the treatment. So they have reached that stage only because of creating this public awareness and platform and more of a discussion forum. So they're able to pick it up at a very early stage, and which is ultimately resulting in less morbid treatments and better survival outcomes. So we in India are lagging, but we are not very far behind. So the intention of such kind of forums and discussions is to create that awareness. And as Dr. Vinod sir was telling, every woman aged 40 years and above, they need to undergo breast cancer screening. A very simple test called Mammogram, which is, I think it's available in almost every nook and corner of the city. So wherever possible, they can undergo and they can come. And apart from that, like the certain risk factors also, which everyone should know, which you have to educate your surrounding people. We as medical professionals, it is our duty to educate everyone in and around us. So I'll be discussing about the risk factors and certain genetic conditions which will result in breast cancer and all those things further in my later talk today. So thank you.
Well, I thank all the dignitaries. We know like it's very crucial time in the morning, coming early, like on the time, like the traffic. Some of you stuck. Still, you made your precious time with us. Thank you so much, all the dignitaries, for coming on time for to make this program the success one as we begin our day to learn and explore more about breast cancer and to give awareness to people so that we can deliver what we have learned. It is thank you so much for all your support. That once we healthcare workers are educated and knowledgeable about this, we are like we ensure that we go out and reach the people to make their knowledge updated and they get screened for themselves. And definitely I do promise that whatever we learn here, it's going to reach the people out there. So thank you, sir, for your support and coming here for support us, all the center heads. Thank you once again, sir. Thank you, ma'am, Swati ma'am, for encouraging and making this program the great one. Thank you, ma'am.
నెక్స్ట్ స్టాప్ చేసి పెట్టు నువ్వు చెప్పు
Now we'll start with our program now.
Moy at the rate of medical dot in. Medical capital at the rate of 2022. It is wrong. Open the web mail. NS dot Moy at the rate of medical. Hospitals. Hospital dot in. M capital. Recovered at the rate of 1973. 1973. Dr. Sadik. Susie.
Can I request all those who are sitting there to come and occupy this front two seats? Offline viewers, online viewers, any queries you can please enter in the chat box. We can answer your queries. I call upon Dr. Sadvik to give us an overview of breast cancer.
I think we're already late by the schedule, so I'll try being as brief as possible. So basic agenda for this talk is to give basic idea about what breast cancer is. And when you're seeing a patient in the IP or in the OP or in the daycare clinic anywhere, you should understand what is happening with the patient. And if needed, you should be able to counsel the patient about few risk factors and other things. Okay. So coming to a very basic thing, what is breast cancer? So simple thing is cancer happening in the breast is breast cancer. But what exactly is cancer is any abnormal, uncontrollable, and continuous replication of cells without any check. That leads to a tumor, and then slowly it spreads locally in the breast, and after that it starts spreading to elsewhere in other parts of the body. Next slide. Click on. Coming to the anatomy of the breast, majority, the bulk of the breast tumor is fat, and only 10% of the breast is filled with lobules, ducts, and lymph nodes. And the cancer, what we see is among these parts, the 10% of the breast, which consists of the lobes, ducts, and lymph nodes. This is where all the malignancy happens. And remaining 90% of the fat does not play much role in it. And if you look at the classification of breast cancer, this is important. Very broadly speaking, it is classified into two parts. That is, either it's an in situ carcinoma or is it an invasive. How do we say in situ or invasive is, if the tumor cells have breached the basement membrane, then we say it invasive carcinoma. And this is a more common one we should be seeing in our day-to-day practices. And if it has not yet breached the basement membrane, it is called in situ. So this basic differentiation is important because both of them are managed in a different way. In situ tumors, most of the treatment would be based on surgery. Whereas invasive carcinomas, all modalities of cancer therapy like surgery, radiation, medical oncologists, all will be involved in the treatment planning. And as well as prognosis wise, in situ people have better survival when compared to the invasive carcinoma people. Then coming to the breast per se, breast can be divided into 5 areas. As you can see on the screen, upper outer quadrant, upper inner quadrant, lower outer, lower inner, and the central area. So if you look at these 5 areas of the breast, around 40% of the tumors, they occur in the upper outer quadrant. This is followed by the central area, the nipple areolar complex, what we call. Around 30% of breast cancers arise in this area. And then followed by upper inner quadrant. So majority of the tumors occur in the upper side of the breast and the central area. So this also has to be kept in mind. Any lumps in this areas, you have to be more proactive while referring a patient to a doctor. Then coming to the spread. So spread can basically happen in 2 ways. One, it spreads locally and to the locally regional areas, and after that it can spread to various parts of the body. So locally speaking, any lump in the breast, a small size lump, which can keep on growing, and then it can infiltrate the skin. And if it grows inside, it can infiltrate the chest muscles. And apart from that, it commonly goes to the lymph nodes in the axilla or in the subclavian region. So after this, once if it starts spreading to the outside body, it can literally go to any organ in the body. But most commonly, breast cancer spreads to the bone. And this is followed by lung and liver. And there are certain high-risk breast cancers which commonly spread to the brain as well. So bone, lung, liver, brain are the common sites where the breast cancer can spread. This is again important because when you're assessing a patient without any radiological investigation, just with a diagnosis, you should be any symptoms, CNS symptoms, you should always be aware maybe they are brain mets, and that is how you have to inform. Now coming to the epidemiology, why so much hangama about only breast cancer? I mean, there are many other many other cancers as well, but a lot of awareness programs and a lot of media publicity, everything goes to breast cancer. The reason that being is the cancer burden. There's globally more than 10 lakh women who are diagnosed with breast cancer every year. And it is, as Jewelry Sir, Vinod Sir, I have already quoted, it is the most common type of cancer in women. Apart from that, it's also one of the leading causes of cancer-related death in women. So because of this, because of the high cancer burden, high cancer mortality, that is why it has become such an topic of discussion. And if you look at the death rate, every year there's more than like around 600,000 women who are dying of breast cancer. And but the good part is because of more awareness and more advancement in the treatment techniques and availability of newer and newer molecules, the death rate has been steadily declining. If you look at compare with the death rate from the 90s, there's around 40% reduction in the breast cancer death rate. This is all because of not only advancement in science, but because of early detection, because of more awareness among people, and at the same time, newer and newer molecules which have been discovered. So coming to Indian perspective, in 2020 alone, there are around 2 lakh new cases of breast cancer which were diagnosed. And among them, there are around 90,000 deaths. So again, not only in worldwide, even in India, there's a huge cancer burden because of this. And that is why it's very important. And another thing is, previously, most of the breast cancers, and even now, 50 years and above is the age group where we see most of the breast cancers. But what we have been noticing of late is a lot of young women are also being diagnosed with breast cancer. If you can look at this plot, 25 years back, if you see, women between the ages of 30 and 40 years, the incidence was around 7%. But now it is almost double. That is 30 to 40 years age group people, there's a 16% risk of developing breast cancer. So it is not only elderly, slowly and slowly, even younger women are being more prone to breast cancer. There are multiple explanations for this. It can be the Western lifestyle or more obesity, which has become a problem. And the other thing is more population which is there in the 30 to 40 years age group. So it is multifactorial, but what we have been noticing is even young women are getting prone to breast cancer. And unfortunately, though these people tolerate treatment much better, their cancers have been more aggressive when compared to the people with the elderly age group. So now coming to the few symptoms of breast cancer, what you should be aware. One most commonly how a breast cancer presents is with a lump in the breast. And usually it is not seen by the eye, and you have to palpate it, and that is how you know there is a lump. Apart from that, change in the size or shape of the breast, or any change in the color, any nipple discharge, maybe blood or serosanguines, and change in the skin texture, change in the nipples, any inverted nipples, anything like that, or even a rash or crusting. So any of these symptoms is a warning sign. We have to immediately go and consult with your doctor and get evaluated whether it's a tumor or whether it's a cancer or not cancer. This is important because this is what you'll have to educate people. And then that is with symptoms. But if you want to catch breast cancer even before a symptom develops, there are multiple screening modalities. And most common screening modality, what we use is mammogram. And mammogram along with an assistance of an ultrasound scan. Apart from this, few case scenarios where there's a family history or genetic risk, and if you want to start screening for breast cancer at an earlier age, even MRI scans are used for screening. So the recommendations, various societies, American Society and other worldwide societies, the recommendations are different. What age to be screened for breast cancer? What we routinely advocate here, at least in our center, is we ask women of age of 40 years and above to start getting screened for breast cancer with a mammogram every year. And once you get a mammogram report, you'll basically have a scoring system in the mammogram, the score of 0 to 6. So anything 1 and 2 is nothing to be worried about. You can just keep the patient on follow-up, ask them to come back after 1 year for a repeat mammogram again. If the report says a score of 3, then it is probably benign, not really sure. So you keep the patient on a close follow-up. You ask them to come back after 6 months to get tested again. Again, when the score of 4 or 5 is given, that means it is suspicious. Chance of the lump or tumor, whatever is there in the breast, chance of that being cancer is pretty high. So score of 4 or 5, you have to intervene. You have to advise the patient to undergo a biopsy. So biopsy is a final diagnostic test, which will give a confirmation whether the lump in the breast is a cancer or not a cancer. So why we have been discussing about the symptoms and all the screening modalities, ages and everything is by detecting it early, what all we have been trying to highlight from the beginning is it reduces the mortality of cancer. As I've told, in the last 2 to 3 decades, breast cancer mortality has been reduced by around 40%. And this has been possible only because of early detection, awareness, and screening programs which have been implemented. Coming to India, it is not so widely implemented yet because of lack of awareness. But Western countries, it is very strictly implemented, and there's a lot of awareness among the public. Apart from the mortality, another important thing is morbidity. The lesser the stage of the disease, lesser modality of treatment, easier surgeries, and lesser side effects of the therapy. More advanced it is, more modalities. Like for example, stage 1 tumors of breast, they may end up having a surgery and no treatment at all. But if it's stage 2, stage 3, they will be requiring chemotherapy, surgery, radiation, which will extend the duration of hospital stay. At the same time, increasing the side effects of the treatment as well. And another very important aspect, at least in Indian scenario, is if we're able to detect the cancer at an early stage, it will definitely reduce the cost of treatment. In India, on average, early stage breast cancer, they would require 4.5 to 6 lakhs of rupees for treatment for the entire course of treatment for 6 months. But as the stage increases, that amount may get doubled, 8 to 9 lakhs, and in some situations, it may be even more than that. So that is also important. It's not only physical toxicity, psychological toxicity, but a lot of financial toxicity also if you get delayed in diagnosing a breast cancer. So this is again mostly Western data. If you can see, it is not 95%. Western countries, if it's a localized breast cancer, the 5-year survival rates in certain conditions have been 99%. So that is important. You're almost able to cure 99% of the breast cancer patients if you're able to detect in early stage. So that is why the screening programs and awareness play such an important role. But if you see the third thing, if distance spread, that is if the cancer has spread to other parts of the body, that is we call metastasis, the survival has dropped to less than 1/3, that is 30%. 30% that too in Western countries because they have a lot of clinical trials and a lot of newer molecules also available. In Indian scenarios, it will be even worse than that. So that is the important importance of having a diagnosis made early rather than delaying it. And if you look at an average 5-year survival of a breast cancer patient in Western countries, it is more than 90%, as I've already shown. Whether in India, if you compare it with India, it is around 66%. So there is still a lot of gap between our survival, our patient survival, and their patient survival. So that is where all this education, patient education, medical professionals education, all things come into play. Now, coming to risk factors of breast cancer, broadly we can divide them into modifiable causes and non-modifiable causes. Non-modifiable causes are like gender. Obviously, women are at more risk of developing breast cancer compared to male. Aging, as I told, people aged 50 years and above are at more risk of developing breast cancers. And certain genetic risk factors, which I'll be discussing later. And family history of any breast, ovarian cancer, or pancreatic tumors. Personal history of breast cancer. Even if a patient has developed breast cancer, they're always at risk of developing another cancer in the opposite breast as well. And then menstrual cycles. That is, if they have an early menarche and late menopause, such people are exposed to a long duration of estrogen. So these people also have high risk of developing breast cancer. So these are the factors which cannot be modified, but there's certain lifestyle habits which can be modified, and these have to be advocated because by modifying these risk factors, the chance of developing a breast cancer can be reduced. So this is more like a prevention rather than diagnosing. One is oral contraceptive use and not having children, hormone replacement therapy, not breastfeeding the children, and alcohol use, obesity, diet having a lot of fat content, physical inactivity, that is again leading to obesity, and smoking to some extent. So regarding the risk factors, I'll be just briefly discussing about the genetic risk factors because there's a lot of information coming out about genetic risk factors, and everyone should be aware of it because if someone asks, you should be able to answer about them. If you look at all the breast cancers, around 5 to 10% of them are because of the genetic mutations which happen in them. And most common genes are the BRCA1 and BRCA2 genes. There are other genes like P53, PTN and all, but they're less common. BRCA1 and 2 are the most common ones. And when a person has these genes, the lifetime risk of developing breast cancer, other cancers is pretty high. And apart from that, usually patients with mutations in these genes develop a breast cancer at a young age, and they have a very aggressive tumor as well. And this slide I've just put because the importance of public awareness. When Angelina Jolie underwent double mastectomies, there was a lot of media coverage for that. And following so much of media coverage, what happened is immediately there were around 40 publications about BRCA genes and breast cancer prevention and breast cancer screening modalities and all these things. And there was a lot of patient inquiry about the BRCA genes, and there's a lot of increase in the testing of the BRCA genes and a lot of acceptance. Not only in Western countries, even in India, there were a lot of people who are asking about what is this Angelina Jolie gene and what can be done to prevent breast cancers and things like that. So this is how awareness, public awareness creates a lot of role. Just one celebrity having it and a lot of media coverage, and then that has completely changed the picture of BRCA testing worldwide. And how does this help is, if there's a patient with a BRCA mutated gene, even before a cancer develops in that patient, you can act beforehand and do prophylactic surgeries, prophylactically removing the breast and prophylactically removing the ovaries. This will reduce the risk of developing any cancer by around 95%. So that patient may not develop breast cancer in their lifetime because of acting before. So this is a risk, like what is the risk of developing in breast cancer with respect to gene? If there's a BRCA1 mutation, then there is 50 to 80% chance in their lifetime that they'll develop breast cancer, and around 40% risk of developing ovarian cancer. So, and if there is BRCA2, again, there will be around 60% risk of developing breast cancer, around 20% risk of developing ovarian cancer. And if, I mean, males are not immune to cancers because of this gene. If there's a male patient with a BRCA2 gene, then they're at risk of developing pancreatic and prostate cancer. So apart from identifying gene, what is important is counseling. So if a parent has this gene, there is a 98% chance that the kids will also have this gene. So it is not only identifying and treating the patient, but you have to give a lot of familial counseling also, because their siblings and their children and all may also be affected by this genes. Then coming to the subsets of breast cancer, this you should basically know that breast cancer can be, they are classified as ER positive, HER2 positive, or triple negative. Treatment is beyond the scope of today's discussions. I'll just be telling what these are. Majority of the breast cancers ER positive. ER positive means estrogen receptor positive breast cancer. And these are the ones which have good biology, slow growing tumors. They have good prognosis, good survival. And then there are the other two types, HER2 positive and triple negative. The HER2 positive ones, initially, they're actually aggressive tumors. And initially, a few decades back, they did not have such a good prognosis. But with the advancement of science and with a lot of newer molecules available, now these patients also do as good as the ER positive. So only area where breast cancer treatment is still lagging behind is triple negative. These are the patients where we do not have very good molecules till date, and the survival is still lacking. And that is the most aggressive variant of breast cancer. So coming to the treatment, it is breast cancer is one of few malignancies where all aspects of oncology team is involved. That is medical oncologist, surgical oncologist, the pathologist, radiation oncologist, nuclear medicine doctor, the nursing care and palliative care, all of them. And the three main treatment strategies are surgery, radiotherapy, and anti-cancer drugs. Anti-cancer drugs can be chemotherapy, hormonal therapy, targeted therapy, many other things. But the mainstay of treatment for breast cancer, even till date, has been surgery, and surgery followed by chemotherapy, or surgery followed by radiotherapy and chemotherapy, all three aspects. Regarding the treatment, I think my other colleagues will be discussing about them in the further talks. I'll not be talking much about them. With that, I would like to conclude my presentation, and I'll be happy to take any questions. Okay, and I assume there are no questions.
Online viewers, any question? Any questions down there? Suman? No doubts. Sir, I have doubts. Sir, this particular gene, like all of them, like who all should be screened for this particular gene, sir? Do they have any symptoms? Like, how will they know that they have?
People, even without symptoms, we ask them to get a BRCA1, BRCA2. It's a blood test. It is not some complicated thing. It's a genomic testing, but we usually send the blood sample for it. So multiple family history of breast, ovary, pancreatic or prostate cancer. Or if someone in the family is already known to have that mutation, then we defaultly advise for a BRCA mutation analysis. So it's not based on symptom, it's based on the history. What age did your grandmother have ovarian cancer? That is young. I mean, she can get tested for BRCA mutation, but the chance of that being positive will be somewhere less than 10%.
Anybody else? Any question? Thank you, sir, for giving a brief overview of breast cancer. Was this presentation informative? Then why no doubts? Everybody understood? It was so clear. Thank you, sir. Thank you, sir, once again. Yes, sir. Please, Mike. Sir has a question.
Not for breast cancer.
Thank you, sir, once again. Now I call upon Dr. Sharat Chandra for giving us, like, once again, brief overview of this investigation and diagnosis. What should we notice on this breast cancer diagnosis?
Yeah, hi. Good morning, everybody. So I was given this topic, investigation and diagnosis. Although I'm a medical oncologist, this is a radiologist domain, but I'll still try to cover it as best I could. So breast cancer, you'd like to know about what is called triple assessment, where any particular symptom is being assessed by all the three modalities. Like you take a brief history and clinical examination, followed by the investigations. Those are the radiological investigations, the imagings varying from mammography, ultrasound, and MRI, and then with a tissue diagnosis from all the various three different modalities, FNAC, core biopsy, or excision biopsy, come to a diagnosis of breast cancer. So I think Sadhvik sir has already touched upon the different signs and symptoms, but then I'll briefly touch upon them again. So a palpable mass in the breast would be the most common presentation of breast cancer. Any nipple retraction or discharge you have to worry about. Then any skin thickening that is because of the involvement of skin lymphatics. A specialized appearance of an orange is also there when it is involved by the skin, where it is a little advanced. Or you get masses in your palpable masses in your axilla is one of the breast cancer symptom, where it has spread to the axillary lymph nodes. Or sometimes the mass is already fixed to the chest wall, where it is immovable. So these are the various investigations we have to diagnose your breast cancer. The most common thing is mammogram. Then we have breast ultrasound, a digital mammography, and then you have computer-assisted mammograms, which we don't do here. So when coming to the mammography, it still remains the standard for the evaluation of almost all the breast abnormalities. It is almost all the breast cancer typically seen as an ill-defined mass with speculated margins, with or without micro calcifications, where they are rated on the basis of BIRAD scoring from anywhere between 0 to 6, and then how the different percentages of breast cancer is in the previous presentation. So it is useful both as a diagnostic and as a screening procedure. We generally use mammography more as a screening procedure, and then taking it from there. So the sensitivity and specificity is a little low, but then slowly with all the adjunct procedures, it is gradually picking up. So after mammography guided FNAC by biopsy, the detection rate of malignancy is close to around 30% in screened patients. So why mammography is important is mammography can show changes in the breast up to 2 years before a physician or any other guy can pick it up by examination. So that's why it is included in the screening programs. So it remains the most cost-effective approach for breast cancer screening. The sensitivity and specificity are not ideal, but then this is the best we have. So when we include clinical breast examination to mammography, the sensitivity and specificity increases a little. So there are different guidelines of breast cancer screening. The most common one which is followed is given by US Preventive Services Task Force. They um, specified an age of 50 from where the routine screening should actually start, although different societies have given an age of 40. We, like Dr. Sadvik had mentioned, we generally start our screening programs at age 40 only. So routine screening should actually end at age 74. So as per this particular task force guidelines, women should actually get mammograms every 2 years instead of 1 year. Although this is a broader population guideline for US, but then this is cost effective over there. So we generally do it almost routinely every year after an age of 40. So coming to mammography, it is used as a low dose X-ray system. So conventional screen film mammography, which is there at our center also, we don't have digital mammography here. So digital mammography is one thing which replaces the X-ray by solid state detectors that converts the X-rays into the electrical signal. So these are just basics of different mammographies which is available. So you don't have to know about all this, but then digital mammography, the sensitivity is superior to the screen film mammography in younger women, and then in women with more dense breasts. We also have an adjunct with the MRI where dense breasts are screened with MRI sometimes. So computer aided diagnosis is also one modality which is not available presently here. So screening mammograms, there are two views which are taken. One view is mediolateral oblique, and then one more view is craniocaudal, and then with the mixture of these two, we come to a diagnosis. So the possible findings on an abnormal mammogram is all these which you can see. There could be a speculated mass or just an architectural distortion, which is even an earlier sign than a speculated mass, where it could later convert into a proper breast cancer. There could be abnormal calcifications, sometimes mass plus calcifications. Basing on all these, a particular scoring is given on every mammogram. So malignant masses actually present as a speculated appearance, and when compared to the benign mass, you can see the pictures just adjacent. So the left one is a malignant mass where you have more speculated appearance than the one on the right, where it is more broader. So coming to calcifications, so non-cancerous calcifications you can see on the left, and cancerous calcifications you can see on the right. They are more rounded, and here they are a little more irregular and speculated. So coming to this particular final assessment, where Dr. Sadvik had already mentioned, after every mammogram, the abnormalities are graded on the score of 0 to 6. 0 is actually one where the mammogram has not been done properly, or you actually need a further imaging to rate that particular abnormality. So in BIRADS 4, there are again three more classifications: 4A and 4B and 4C, where the chance of the abnormality being malignant is a little high depending on A, B, and C. So this one thing you have to know: in younger patients, you have more dense breasts. So in dense breasts, the mammogram lags behind in picking up all the abnormalities. Sometimes in younger patients with dense breasts, you might ask for an ultrasound or maybe an MRI to pick up any abnormalities. So then coming to ultrasound, it is also a useful tool to complement mammography in diagnosis and treatment. Here at our center, we actually complement every mammogram with an ultrasound, then read the abnormalities on that particular imaging. So it can be also used as a guide for interventional procedures. So all our biopsies are being done with the ultrasound guidance. So, and then one more use is an evaluation of a lumpectomy cavity site for planning the radiation boost as part of the treatment. So ultrasound is also limited by a number of factors because most notably by the failure to detect the microcalcification. That's why we use ultrasound plus mammogram both as an adjunct to finally rate our tumors and come to them. So one more modality is breast specific MRI, where it is those particular instances where breast MRIs are done. I'll just discuss. You have an abnormality which is not picked up by mammograms and ultrasound. Still, the patient has some symptoms. You then go for breast MRIs. So there you can see one particular breast MRI picking up mass nicely, which is missed by mammograms and ultrasounds. But you only have a few instances where MRI is specifically advised. So MRI is good with um, young patients who have dense breast. Sometimes it is indicated for staging in a particular subtype called invasive lobular cancer. It is not routinely used for staging. So those difficult circumstances where mammograms and ultrasounds miss, and then you then specifically ask for MRI. So other indications are evaluation of a patient in an unknown primary tumor where you only have axillary lymph nodes and there is no mass picked up in the breast. Maybe an MRI, breast MRI can pick it up. Sometimes people have breast implants where the irregularities may be picked up by a breast MRI. Sometimes evaluation of a patient with positive surgical margins after your lumpectomies could be done with breast MRIs. And then these days we do a lot of neoadjuvant chemotherapies, meaning we give chemos to reduce the tumors and then later take them for surgery. So the monitoring of the tumor sizes could be done by MRI. So the limitations of MRIs is a lot of very high chance of false positivity. We cannot use it for a routine screening program. And overlap of different benign and malignant conditions. It is difficult to pick up which is normal and which is abnormal most of the time. So, and also there are a lot of false negatives. So like I told you, it should not be substituted for mammogram or ultrasound. Only specific indications MRI should be used. So it should not be used as a substitute for histological diagnosis. You always need a biopsy or in some cases an FNAC to prove your cancer, and MRI is not the final call. So the other imagings which we commonly use in breast cancer is the ones like your CT scan, bone scans, and PET scans. You all know we routinely use PET scans for staging, although in early stage there is the guidelines don't suggest for a routine use in early stage, but then again we commonly use it because of convenience. The present status of PET CT, if I can put, so evaluation of patients who are suspected of having a tumor recurrence or to identify patients with multifocality where there are more than one lesions in your breast. So then you don't need to know all that. So in stage one, as per guidelines, there is no role, but we still go ahead and do it because of convenience. In advanced stages, there is a possible role for it. So once there is an abnormality, maybe be it on a mammogram or an ultrasound or an MRI, the next step is tissue diagnosis to confirm it. So how do you do it? Is we have three different modalities. One is the fine needle aspiration cytology by biopsy. Some people do fine needle aspiration biopsies also elsewhere. Core biopsies and excision biopsies. So coming to FNAC, because why FNAC we need to discuss here is there are a few centers where there is no possibility to do biopsies over there. They rely more on FNACs, but you need to know what are the fallacies in it. So it is quick, cheap, and well tolerated for most of the palpable lumps. Most of the rural areas depend on FNACs for all the diagnosis of different breast lumps. So a considerable cytology expertise, that is a good pathologist, is required to identify or diagnose breast cancers on on the basis of FNAC only. Sometimes definitive diagnosis of some lesions difficult to make. So these are all the different fallacies of fine needle aspiration cytologies. So there are a lot of disadvantages. It is difficult to assess the different microcalcifications, and it is difficult to distinguish between sometimes the early ductal carcinoma in situ, which are not proper cancers, when compared to the invasive carcinoma. So it is difficult to distinguish between these two when you go by only an FNAC. So ductal lavage, these days no one does ductal lavage. So when coming to cytopathology, the reporting protocol, there you go. So these are basically a pathologist domain where they give different scoring, and as per C1 to C5, you know which lesion is benign and which one is malignant. So coming to the most important tissue diagnosis, core biopsy, which we routinely do to diagnose the different suspicious breast lesions. So it is percutaneous vacuum assisted. So we generally do USG, so ultrasound guided core biopsies to diagnose different breast cancers here. So palpation directed. So sometimes you just palpate the lesion and then insert the biopsy needle into the specific site, or like how we do image guided. So most common image guided biopsies which are being done is ultrasound guided. So image guided, you can also put a clip in that particular site, so that you can follow it up when you're giving chemo upfront and then taking them for surgery later. So this is about core biopsy. So one more thing is wire localization, where at some centers, when they are using a strategy of starting with chemo first, followed by surgery later, they localize the tumors with a clip or a wire and follow it up later to actually know the site of surgery, because chemo shrinks your tumors to almost a considerable extent. So indications for core biopsy. So further evaluation of a lesion for which cytology results are atypical or suspicious, like some patient had come with a cytology which is inappropriate or inconclusive, and then we go ahead with the core biopsy. So evaluation of all the different microcalcifications which are picked up on a mammogram. So evaluation of a suspicious architectural distortion which is picked up on a mammogram. So evaluation of an area which has been treated earlier with radiation. So relative advantages when compared to FNAC is core biopsy is the investigation of choice and the evaluation of microcalcifications. It could be used when FNAC fails to correlate with clinical findings. It allows the architectural features of the lesion to be identified to determine whether it is just an early carcinoma in situ or an invasive carcinoma. So compared with FNAC, core biopsies may achieve higher specificity and sensitivity, which is actually more important in diagnosing. And the tissue is actually available to subtype the cancer, which is very important for us to know which particular chemotherapy drugs to be put on. So the disadvantages, like you can say, on paper, maybe a hematoma or a hemorrhage, but these days we use ultrasound image guided core biopsies. The chance of hematomas and hemorrhage is very minimal. So core biopsies require adequate fixation and processing, which is it is not a disadvantage per se, but it is actually the need of the hour to come to a conclusion, and then it is generally more expensive than FNAC. So all these things we are generally talking when compared to FNAC on a broader level. So here at our center, we generally do core biopsies only to diagnose breast cancer. So incisional biopsies, is a surgical procedure where only a portion of the tumor is removed, and then we have exceptional biopsies. It's similar to a lumpectomy. So this is called a mammotone or a minimally invasive breast biopsy, which is not available here, so you don't need to know. So the other diagnostic techniques apart from imaging and biopsies which are available are tumor markers, which are not that specific, but sometimes maybe in a metastatic setting, one could follow them as an early indicator of disease progression or recurrence by doing CA 15.3 or CA 27.20. So that's it. Thank you. About all the imaging and diagnosis. About all the So this is about all the imaging and diagnostic facilities which would be needed when diagnosing a particular case of breast cancer, although this is not my modality. So if there are any questions, I'm happy to answer.
Anybody in investigation? Online viewers? Thank you, sir, for giving us rich informative information about this investigations and diagnosis. Now we'll have a short tea break for 10 minutes. Please gather in the OMG auditorium and come back in 10 minutes. We'll continue with the other session.
We are giving 10 minutes to do. Please. Already ready? Breast. ये क्या था? ये क्या था? ये कौन सा एरिया तो इतना नहीं जगह है? ला लो मशीन, मशीन ला लो. बोल रहा हूँ कि मशीन ला लूँ, मार दो. అది దీనికి రాదు.
Thank you all for cooperating, except that brother and Glory. Okay. I think nobody is sleeping here, right? Let's continue with our program. Now we have our anesthesiology ma'am, anesthetist, Dr. Yashashwini, and she comes here with rich experience, senior resident, senior resident, okay, MD anesthesia, and she's here to give us, talk about how do we prepare a patient, breast cancer, any cancer patient, especially breast cancer patient for surgery, pre-operative preparation. I welcome you, ma'am, to give us a talk on preparation, pre-op preparation.
Good afternoon, one and all. Thank you for giving this opportunity. So I'll be talking about pre-operative preparation of patient undergoing breast surgery. So by now, patient would have had lot to digest. Surgeon would have advised for surgery, and they will, by the time they come to us, they'll be very stressed out and confused and very anxious. So we have to even deal with their psychological and emotional needs also. So first, I'll be talking about the pre-op evaluation of patient. Here, provides us an opportunity to assess the patient in all aspects, to describe the anesthetic plan with the patient, and to provide psychological support, to allay anxiety, to address their emotional needs, obtain informed consent, and optimize their current comorbidities. So we take a detailed medical history. We ask whether they are hypertensive or diabetic and asthma, thyroid diseases, and all. We take a very detailed medical history. And then we even ask for drug history also, because this is very important for us, drug history, because some patients who are on antiplatelet, dual antiplatelet therapies, they're like clopidogrel and aspirin. Clopidogrel has to be stopped at least for 5 days before surgery. So this is a very important information that we gather, and we even ask for any allergy history. So and history of any previous surgeries or any anesthetic exposure, and chemotherapies, radiotherapies, and hormonal therapies also. This is very important for us, chemotherapy histories and all, because once if the patient is some chemotherapeutic agents like cyclophosphamide and doxorubicin, they're cardiotoxic and they cause cardiomyopathies. So we need to assess the cardiac dysfunction before the surgery. So we ask for a cardiac cross consultation also here. And yeah. And some neoadjuvant chemotherapies can cause even hematopoietic adverse effects, like they can have perioperative anemia and increased bleeding from thrombocytopenia and neutropenia. So identification and management of these things are very important before surgery. Then we'll have a general physical examination of the patient, where vitals are checked, height, weight, BMI, all these are checked. Then we go for a systemic examination. It includes CVS, RS, CNS examination. And airway examination is very particularly important for us, because our plan of anesthesia depends upon this completely. Um, uh, we look for a mouth opening, adequate mouth opening and neck movements of the patient. Then we look into the major surgical profile. This includes CBP, serum electrolytes, urea, creatinine, chest X-ray, ECG, thyroid stimulating hormone, TSH, and HbA1c, RBS, all these things. They come under major surgical profile. Each and everything has its own importance, and any abnormality in above things like investigations or any history, then we go for cross consultations. Like most of the times it would be cardiology cross consultation, because most of the patients, or a few patients at least, they would have had chemotherapeutic interventions before coming for surgery. And any patient suffering from any upper respiratory tract infection or any asthmatic patients, they go for pulmonology consultation. And uncontrolled diabetics and thyroid patients who have high TSH levels, or they will be, they will have a cross consultation with the endocrinologist. We even ask for blood and blood products reservation, depending upon the risk of bleeding and the preoperative HB levels and all. And this is one more this ASI classification. This is American Society of Anesthesiologists classification. This helps us to assess the patient physiological status, and even it predicts the perioperative risk of surgery and outcomes. So ASI, it goes like this. We try to fit in the patient in one of these classes. So ASI class 1 patient is a normal healthy patient. Class 2 patient is a patient with mild systemic disease. Class 3 is a severe systemic disease that limits the activity, but it is not incapacitating. Class 4 patient is a patient with incapacitating disease that is a constant threat to life. Moribund patient, class 5 is a moribund patient who is not expected to survive without surgery. And class 6 is a brain dead declared patient. Then we discuss the plan of anesthesia with the patient and patient attendant, counseling regarding the risks and complications from our side, and we take an informed consent. This will be taken on the day of surgery, and we give clear instructions to the patients what to do and what not to do before surgery. And these are few investigations that we give for the patient. Most of the patients, they get breast surgery patients who come, they get admitted on the day of surgery. So we ask them to stay NBM, that is nil by mouth, from midnight or at least for 6 hours before surgery. And if the patient is on any antihypertensives, like beta blockers, they can be continued. So most of the nursing staff will have doubts regarding this, because sometimes we ask them to avoid antihypertensives and sometimes we ask them to continue. It's if the patient is on a beta blocker, plain metoprolol or something, they can continue it. Any beta blocker, they can continue it without any combination. And if it is any ARBs are like telmisartan, candesartan, all these things, they can be discontinued. And AC inhibitors, enalapril, all these things also should be discontinued because they cause profound hypotension in the intraoperative period because of because of anesthetic drugs and these drugs interaction. There will be profound hypotension. So we ask them to discontinue those drugs. Anti-diabetic medications should be skipped because patient will be fasting. And if the patient is on insulin, uncontrolled sugars patients, most of them, they will be on insulin. So that depending on endocrinologist suggestions, that should be continued, insulin. And that is like a patient, it depends on the patient. You can't generalize and say that this should be discontinued and that should be continued. And thyroid medications can be continued. Anti-epileptic medications also should be continued. Antiplatelets and anticoagulants, as I have told earlier, should be discontinued for a minimum period before, as advised by that also we take a cardiology advice. So anxiolytics on the previous night should be given for extremely anxious patients. And smoking, alcohol, and any herbal medications should be stopped at least 2 weeks prior to surgery. Smoking should be stopped at least 6 weeks before surgery. Now, on the day of surgery, in the pre-op area, patient usually gets on admitted on the day of surgery. So by now, the patient would have developed some rapport with the anesthesiologist, but still most of them continues to be anxious. So now patient is put on an OT gown, the site marked, and vitals and GRBS are checked. IV cannula is placed usually on the contralateral arm to avoid upper limb lymphedema of the ipsilateral arm, like on the side of, if suppose the surgery is on the right side, we prefer the left side to have a cannula. And IV fluids during fasting period should be administered at a rate of 1 to 1.5 ml per kg. In the pre-op area itself, we start IV fluids. The patient is asked to empty the bladder before shifting inside the OT. If it is only short surgery, if it is any long duration surgery, like in any reconstructive surgeries like LD flap and all, we usually catheterize the patient. So yeah, in extremely anxious patients, 1 mg of midas is given in the pre-op area itself before shifting the patient inside OT. Now inside OT, usually it's females, so most of the times we comfort the patient by only female nursing staff and female housekeeping will be inside after while connecting the monitors and all the male staff will be sent outside for a few minutes, and after draping the patient, covering her enough, then all the male staff enters the OT and for the surgery. So now pulse oximeter, NIBP cables are connected to patient. In cardiac patients, we go for invasive arterial blood pressure monitoring. And the type of anesthesia depends on the duration of surgery. If, suppose it's a shorter duration surgery, we use supraglottic airway devices like iGel, Procel LMS. And if it is for if it's a longer duration surgery, we go for endotracheal intubation. And antibiotic prophylaxis is usually given at least 20 to 30 minutes before procedure. And we go with a multimodal analgesia inside the OT. And now positioning the patient, this is very important because most of the surgeries are done in supine position except for a few reconstructive surgeries like LD flap and all, where patient is positioned laterally. Later in that surgery also patient will be put in a supine position again. Here patient will be in supine position with the arm hyperabducted. So this causes a little overstretching of the brachial plexus, and so this thing should be prevented. So all this positioning thing happens under the vigilance of anesthetist. So and the pressure points are padded very carefully, and throughout intra-op monitors are vitals are monitored. And we follow something called ERAS protocol. It is enhanced early recovery after surgery. It aims at shortening the length of hospital stay by facilitating pain control, avoiding excessive usage of opioids like fentanyl, pethidine, and all, and prevention of nausea and vomiting, early mobilization, and early feeding. Early feeding is like the clear liquids can be given as soon as the patient becomes conscious, and when and if there's no nausea, vomiting, and if the patient has achieved the deglutition reflex, like if he can swallow, then immediately we can give water to them, and followed by soft diet after 4 hours after surgery. Post-operative care will be dealt by Dr. Ashwin. Okay, thank you.
Thank you, ma'am, for briefing about pre-operative preparation of breast cancer patient breast surgeries. Now I call upon radiotherapist, Dr. Reshma, to give us Dr. Soy Madhuri to give us an overview of radiotherapy.
Good afternoon, everyone. As as this is a month of breast cancer awareness, my my previous speakers already told you about how the breast cancer patient will present and how to diagnose it, and what are the treatment options. Also, they gave a brief idea for you here. Generally, in breast cancer, first chemotherapy followed by surgery and then radiation therapy with or without hormonal therapy is the main treatment in breast cancer. Okay. Generally, what is radiation therapy? Most of the people won't have any knowledge about radiation therapy, as this is not the normally given treatment. So one should know basic things like what is the radiation and what will happen by giving the radiation, and in breast cancer, what is its role. Okay, here first I'm telling what is radiation and what is radiotherapy. Radiotherapy here, what we will use is high energy X-ray beams. It can be any rays like X-ray, gamma rays. Over the time, previously gamma rays or the treatment, now it is modified, like it is replaced by X-ray treatment and particle. Your thing is particle therapy. Okay, what this high energy X-ray beam will do? It directly targets the DNA in the cancer cell and it will destroy the cancer cell. Then how the radiation therapy is going to affect the cancer cell, and how it is how the patient is going to get benefited by the radiation therapy. Here, of- as we are giving chemotherapy and surgery, all like there is a multimodality treatment. Is there really there is a need of radiotherapy? Many people will come up with this doubt. Okay, here what radiation therapy is doing is it is like by giving the radiation therapy post surgery, we are reducing the recurrence rate. It is similar to that of surgery. In surgery, what we are doing is we are removing the bulk of the tumor, whatever possible. We are removing all the tumor, and what is left, like microscopic things which can't be removed by the surgery, will be targeted by the radiation therapy. Okay, and they will also remove the lymphatic lymph nodes. Here, similar to that, radiation therapy is also targeting at loco-regional, like primary tumor and regional lymph nodes. And it is systemic spread, like through the blood or lymphatics. If there is any spread, it is targeted by the chemotherapy. And how will be the machine? This is our our machine in our medical center. This is linear accelerator machine, true beam machine. This is the advanced machine we are having, and like there is a difference in difference in the machines from the previous time to present. Now, many, like lot of development happened. Many technical technology has developed so much. So with the previously, when we are giving radiation, it is targeting a major area. So side effects will also be more. But now we are with the advancement happened, we are our mission is so precisely targeting the tumor by reducing the dose to the nearby structures. Particularly, we are reducing the dose to the critical structures. In breast, like it is very nearer to the heart. So with the newer techniques, newer modalities, we are reducing the dose to nearby lungs and heart. And here we showed the machine with the patient positioned and with breastbone support. And how will you decide the treatment? Individual to individual, there will be some change in the treatment. There will be multidisciplinary team which discuss all the available treatment option for every individual. What this individualization of the treatment do? Like with the by considering patient and tumor related factors, keeping in mind regarding the age of the patient, comorbidities, and ethnicity, and tumor biology, we are taking the decision. What are the treatments to be given? We are discussing for each and every patient, and we are modulating the treatment. This is called tailored treatment. This is a newer thing. Previously, for everyone, it is a normal protocol will be there. Accordingly, treatment will happen. Nowadays, by improvement in the investigations and availability of different like various information for us, we are individualizing the treatment. In addition to that, counseling is very important. In like in every treatment, we are discussing about the outcomes, side effects, and telling the patient regarding the risk factors about this about the survival and the complication happening with the treatment, and how the comorbidities of the patient will affect the treatment. Coming to what factors influencing the risk of recurrence. Mainly, our treatment is reducing the risk loco-regional. So, what are the things we are seeing before and how we are deciding the treatment? So, the main things we are seeing is tumor size and tumor grade, margin status, post-operative margin status, and whether the lymph nodes are involved or not. And we are checking the hormonal status like estrogen, progesterone, HER2, and they're keeping in mind patient age. And these factors, we are for systemic therapy and hormonal therapy also, we are putting all these factors into consideration, and we are deciding whether we have to go with only chemotherapy or endocrine therapy, or is there any need of combination treatment. With the developments happened, there is an like fine tuning of the indications of RT. Like we are individualizing the target volumes where we are treating. In few cases, only breast lump is taken out, and in few cases, total breast is removed. And whenever it is need, they are doing axillary lymph node dissection, or if clinically there are no nodes, they are going with sentinel lymph node biopsies. So according to that, we are changing the treatment volumes. Where we are giving the treatment, we are changing. In addition to that, the changes, we change the time, like time to be treated also. Like time for which the treatment is going on. Previously, it is for 25 days, for 5 weeks we are treating. With the newer things, newer advancements, newer machines, we are cut short, cut shorting the time with the newer schedules, hypofractionation, and accelerated partial breast irradiation. With the treatment time is very less, and we are giving with lesser side effects. As I already told you that there is a like major technical improvement in the machines and the techniques used. Like you might have heard about 3D CRTs, IMRTs, IGRTs, at least the word you might have known. What are these techniques doing? At least you should be aware of few things, and you can tell your known persons that about the treatment modalities. Previously, we are directly putting up the fields anteriorly and posteriorly. Now after that, it is moved to conformal treatment. After that, it is slowly changed to intensity modulation radiotherapies and daily image guided radiotherapies, where we can check daily treatment volumes and we can modify on couch patient movements or any errors in the treatment delivery, like how we are giving when we are giving radiotherapy. Post surgery is the major indication of radiotherapy. In addition to that, if there is a metastatic disease widespread to other parts like bones, brain, spinal cord, we can give it as palliative radiotherapy. Even in metastasis, there is a role of palliative radiotherapy. Here we are treating in pure fractions with symptom. What these are target is just to relieve to give some relief from their symptoms. In addition to that, if there are only fewer metastases, localized single or fewer mets, we can give the curative doses, even targeting to the primary. Post-op radiation therapy, it can be given in both conserving surgeries and mastectomy. In breast conservative surgeries, it is here we are removing only the tumor with an margin. We are not removing total breast. This surgery we are doing only in the early stage of the breast cancer. It reduces the recurrence in the breast and nearby lymph nodes. Similarly, in advanced locally advanced breast cancers, we are going with mastectomy. And in mastectomy, we are removing whole breast. Here, only when the tumor size is more than 5 centimeter, and if there is node positivity, and if there is any positivity of the margins or skin or muscle involvement, we are advising adjuvant radiotherapy. Then, what are the types of radiation therapy? Most commonly used is external beam radiotherapy, and there are few situations where we can give brachytherapy too. What is external beam radiotherapy? It is a most common treatment we are giving in breast cancer. Here, the main thing is machine will be outside, external. The name itself says it is outside. Here, the machine is outside the body. It focuses the radiation on the area affected by the cancer. And area to be treated is decided based on the surgery done and nodal involvement. If mastectomy done and there is no lymph nodes involved, the radiation treatment area is chest wall with a mastectomy scar, and if there is any drain site, will include that. If it is a breast conservative surgery, then will include what like treatment volume is entire breast and will give extra boost. We, um, Here we are removing only the tumor part, not whole breast. So we are giving extra boost to the area where the tumor is. And if if axillary lymph node dissection is not complete dissection not done during surgery, or if there are any high risk factors, we are giving radiation to lymph nodes, axillary lymph nodes. Generally, we won't include axillary lymph node if proper complete surgery axillary resection done. We won't give axillary lymph node radiation. The main reason is patients will develop lymphedema. If we give radiation in addition to the surgery, their complaints will be more, and that lymphedema will decrease their quality of life. And in addition to that, in few high risk patient, we are including supraclavicular lymph nodes. This is above the collarbone. Collarbone is clavicle. Okay. And in addition to that, internal mammary lymph nodes will be there, which is under the sternum in the center of the chest. What are the types and schedules of the external beam radiation? What we are giving is whole breast radiation. That is, we are giving radiation to the whole breast. And there are different type of schedules for treating. It will tell the treatment time, scheduling, and dose. First is standard schedule. This is this thing we are following from the long time. That is 50 gray in 25 fractions. 25 fractions means we are giving 25 days treatment, 5 days a week, Monday to Friday. No treatment on Saturday and Sunday for about 5 weeks. Now near schedule, what we are following is hyperfractionated radiation therapy, where the treatment volume is same, whole breast, but we are giving larger doses here, and the treatment is last for 3 to 4 weeks. The treatment is from Monday to Friday. This is results or are similar to that of the standard schedule, and it will cut short the time, and it will reduce the burden to the patients and also the hospital. Here, in addition to that, we observe there is a fewer side effects with this schedule. Here, I'm showing the machine while treatment delivery. This is how in breast cancer we are giving radiation. We are targeting how beam is coming and targeting the whole breast. And in CT, this is a CT scan axial section where the dose distribution to the breast, like dose covering the whole breast, has been shown. So, this is the newer thing, which is accelerated partial breast irradiation. Here, our target volume is not the whole breast. We are targeting locally to the tumor bed, but where it is indicated in whom we can give. That is the most important thing. This can be tried in only few patients with early stage invasive breast cancer, and the age of the patient must be more than 50 years. In tumors less than or equal to 3 centimeters and no negative patients only, we can try this accelerated partial breast irradiation. This is the diagram, this is the image showing CT CT with dose coverage only to the tumor bed. Here the number of fractions is very much less. We can complete the treatment in 5 days, or we can also complete in single day also. That is intraoperative radiation therapy is also there. It is one of the type of accelerated partial breast irradiation. Here only single dose will be given, and that is soon after surgery. But the machine to give this kind of radiation is not available in all the institutions. And nor 3D CRT, IMRT, these are the normal external beam radiations targeting the tumor bed with more precise dose distribution to the tumor bed and sparing the surrounding normal tissues. Here the treatment is 5 days, both with 3D CRT and IMRT. IMRT is a better technique than 3D CRT, but the only difference is strength of the beam, that is intensity of the beam will vary, and there is an optimization where we can give higher doses to the tumor by reducing the dose to the surrounding tissues. And in addition to that, brachytherapy. We dealt with external radiation. Now we are moving to the internal radiation. In internal radiation, what is the difference is here the device containing the radioactive seeds is placed in the breast tissue. Only in few patients will try this. That too, those patients who fit for the accelerated partial breast irradiation, we are taking for brachytherapy. Here I'm showing the diagram of accelerated partial breast irradiation, different techniques. First one is interstitial brachytherapy. Here needles will place in the breast through which the radioactive seeds will move and deliver the radiation. Only we are sending the radioactive seeds only for a few time and they'll stay there and will come back soon after the treatment is finished. It will come out of the needles and it will get into the source place. Second thing is balloon internal radiation. Third thing is normal external beam radiation therapy with the multiple beams showing in different direction from different directions. Then we told about whole breast irradiation, that is intact breast, where the full breast is not removed. Here chest wall radiation. Here total breast tissue is removed, left over with only the chest wall. After mastectomy done, if there is no lymph nodes positive, we are targeting the entire chest. Here also the treatment time and schedules are similar to that of the whole breast. And lymph node radiation is irrespective of the surgery, type of surgery to the primary. If the nodes, if there is high risk factors that lymph node, axillary lymph node dissection, complete dissection is not done, we are going ahead with axillary lymph node irradiation. And in high risk, wherever the need is, we are giving radiation to supraclavicular lymph nodes and internal mammary lymph nodes. Here also the schedule is same, 5 days a week for 5 weeks. That is a normal standard technique. Nowadays, we are completing the treatment in 16 days. That is 3.5 weeks. This is the gating method, what we are having, newer modality. As you all know that breast is nearer to lungs. Lungs, with inspiration and expiration, there is a lot of movement in the chest wall. While treatment also, it is moving and it is difficult to deliver the treatment. So this is a tracking method. We are delivering the treatment only when at certain phase of the respiration. So treatment will go daily in the same position without missing the target. New thing is this is respiratory gating and deep inspiration breath hold technique. We are already using it now. Recently surface guided radiotherapy, where the treatment is more precise and time to time tracking came and we started the treatment with SGRT. And it is particularly helpful in lung, liver, and breast diseases. In all this, it is very helpful and it will help in tracking the tracking the tumor or tumor bed and delivering the radiation so precisely. And what are the side effects of the radiation? Acute side effects are very minimal. Like only few people will say about swelling of the breast, but most of the people will complain about the redness in the radiation area. At the end of the treatment, few people, if there is any friction or any pressure over that area, skin peeling, dermatitis reactions are common. And there is a common side effect is pigmentation of the skin. We can see by the end of the treatment. Fatigue. For any treatment, oncological treatment, either chemotherapy and radiation, fatigue is the common complaint. And all these skin changes will get better within few months after the treatment. Okay, what is main thing is be aware about the breast cancer, like what are the symptoms and how to self-examine the breast tumors and when to when to start the diagnostic screening methods, and what already Harshvardhan sir told about diagnostic methods. So with all the newer investigations, we are detecting the breast cancer in very early stages. So be aware of the cancer and stay safe. Thank you.
Thank you, ma'am, for briefly explaining the radiotherapy approach to breast cancer. Do any one of you have questions? No one? Online viewers, you can share your queries in the chat box. Nobody has any question? Radiotherapy was easy to understand. Okay, now I'll ask some question if you all don't have any question. Backside? Nobody question? Okay, now what is breast cancer? Dr. Satvik has explained everything from definition till the treatment options. Can anyone tell what is happening? Sorry? Tell me. Yeah, tell loudly. They can't hear me. Uncontrolled abnormal cell growth of tissue, breast tissue. Can anyone list down the causes? There are two different causes, right? Modifiable and non-modifiable. Can anyone tell the modifiable causes of breast cancer? Modifiable risk factors or causes of breast cancer. Online viewers, anybody? What are the modifiable causes? What can be reversed? You're not audible. To some extent, yes.
Oral contraceptive pills, smoking, obesity, dietary habits.
So how can we reverse them all? Inactive lifestyle, main thing what we follow. Okay. Can anyone tell caution full form? This, caution. Tell.
Changes in bowel or bladder habits. A sore that does not heal. Uncontrolled bleeding. Thickening of the limb. Indigestion.
When should one go for screening? How do they identify? How do we tell someone to identify the breast cancer? What they have to look into? How they have to be aware that they have to undergo certain examination, self-examination. Okay. So what are the options, treatment options that are available nowadays? As Madam has spoke just now, there's a technology day by day growing, making the treatment more specific and more accurate, right? So what are the treatment options that we have? The first and foremost thing, if they find the node or limb, something abnormal, they find out it is a cancer, what the doctors do? What are the first preferred treatment and the followed by treatment options? We just learned everything from the doctors to explain. It's okay, you can say.
Chemotherapy.
Combination of treatment, first choice for surgery.
Surgery. Next, chemo and radiation therapy.
Let's clap for her. So, can anyone tell what is benign and malignant? Not this cancer unit. Anyone from IPR? Is there anyone from women and child? Is there anyone from women and child? You are there, oh madam. Okay, someone who is not from cancer in it. Differentiate between malignant and benign tumors.
Benign tumor does not spread to other parts of the body, while malignant spreads to other parts of the body. Malignant is cancerous, benign is not cancerous.
Nobody else wants to talk, only the same people. So what is the screening schedule that we follow in India? Over the age group of people 40 and over, when they should go for routine screening? They come they don't have, even though they don't have a breast cancer related symptoms, still they have to undergo some screening after certain age, right? So how often they should undergo the test? Every 1 year they have to undergo screening. And if you have any family history or any known person in the family having any cancer related issues, they have to undergo the test, blood test, which Dr. Sarvik has explained to us in the morning. So is there any vaccine for breast cancer? No, we don't have. So anybody else, anything, any doubt? Ma'am, DMOs, can any one of you come and share your experience with a patient with breast cancer that you have treated? Dr. Sheen, I would like to call and she will tell us. Please come on, ma'am. Dr. Trinaina, please come forward. Ma'am will share her experience with us and give us some suggestion what we have to follow with when we take care of patients with breast cancer.
Hi, good afternoon, everyone. So, I am working in Moy Daycare, as most of you know. So we go through like many patients every day, and every patient is different. But the common thing in most of them is the mental stress they are going through because of cancer, and especially women with breast cancer. Also, the added hormonal changes or the therapy we are giving, there is a lot going on in their life. So I think it is better, like it is the most that we can do for them is that be mentally there for them, support them, and be as nice as possible whenever they come for chemotherapy or whenever they're coming for treatment. If we are friendly with them, I think that makes the most of it. They are happy. More than the treatment, what matters is how we treat them. So keep that in mind and just be as calm and composed with them as possible. Thank you.
Now we'll departure for our lunch break and we'll be back again by 1:30. Yeah, thank you.
Save it and I'll share the details with you. So how do I do that? Should I share the screen?
Good afternoon, everyone. Welcome back to this session. All of you had lunch? Sleepy? Okay, I think all of us know what is happy or happiness. Have anyone seen it? Have anyone seen it? I just saw a few minutes back. Who is none other than this ma'am Harsha Nagi. Okay, let's give her a round of applause.
Thank you.
Okay, she's the person I just met, so vibrant and so supportive. She's here to share her story with us. Let's once again welcome her.
Okay, everyone, I want a wave of hand to know that you're listening to me. Yes, everyone. Okay, awesome. Great. So I was invited here by Suman to come and share a little bit about my story. So I was wondering what should I be saying to a group of medical practitioners who are so great at their job and who have really literally helped to save my life. But then I started reflecting on it that everyone in their life learns some life lessons through their own story. So let me see if I can make my story as interesting as possible. So the next couple of slides are actually going to be all photos and videos of my journey, and I think through this I would share some little bit of messages with you. Some of these messages might resonate with you. There will be some messages which might be new for you because you've not gone through what I have gone through. But at the same time, I think there could be enough and more for all of us to take back in the next 30 minutes. I'm told I have 30 minutes, so I'll try to keep it short. But the whole idea is to make this interactive. If I ask you something, I would love for you to share your open, honest opinions and suggestions. And of course, it is a two-way street. If I ask you something, I would also expect you to ask me something, or at least share if you agree, disagree. And it's okay to also disagree, because all of us are different and all of us have different life lessons. But the whole point is to make this 30 minutes interactive. I actually did not expect the houseful group, but I am glad to have the houseful group, because it always will leave a great memory with me, that I was part of all of you. So yes, my name is Harsha Nagi. I am a stage 3 breast cancer survivor. Okay, awesome. Thank you for that reminder. Yes, I'm live across 21 other hospitals. So grateful for the opportunity to share my story. It is actually amazing to be here, and it's good to be here in this month, because yes, it is the breast cancer awareness month, and all of us collectively try and do enough and more to spread awareness about breast cancer, which is a silent, any type of cancer can be a silent killer. So yes, okay, let's start with my story. So actually, this picture is from a recent trip where I went snow tubing with my family. That's my family. I am 40 years old. I have two children, 9 and 6, and of course, a very loving, supportive husband. And I like to take life head on. And I'll try to live every moment. So I was very afraid of any kind of tubing experiences, because that sudden escalation of heart rate was not too good for me before my diagnosis. But I have learned to take life head on and experience as much as I can. So in this trip, the reason I put this story here is because in this trip, I tried to overcome that fear, and I went tubing, and I repeated that tubing experience for multiple times, because I realized that I really love it. And I was just fearful of something which was not actually as dangerous as it seemed to me. So yes, that's me. Okay, so I believe that my story is like a journey of transformation, and when I tried to reflect on my story from the last 10 years, so we are in 2022. I've picked up 2013, almost the last 10 years, right? So I want to showcase to you that all life is like a transformation. All of us, I think, if we reflect, we are transforming ourselves every day. And if you reflect on your own journey for the last 10 years, you might be able to realize similar kinds of transformations as I realized. So in this is my first transformation. So in August 2013, I used to weigh 92 kgs, and I decided that this is not good for me. This health is not good for me. I had a 9-month-old baby, and I was not able to run behind my baby when she was crawling. I used to get constant irritation and back pain, and that's when I decided to take life head on, and I decided to lose weight and become fit, become healthy. So that's what I did. I used the next 2 years to slowly and steadily become fit in a very healthy way by leveraging the right kind of food and the right kind of exercise. So that's my first transformation. It happened in the first 2 years, from August 2013 to 2015. Then in 2017, I decided, in fact, between 2015 to 2017, I decided that I have a unique story where, as a mother, I was able to create a sustainable lifestyle for myself and lose weight and also gain health, stamina, energy. So if you can see, from 2013 to 2015, I started looking almost 10 years younger. So this is look wise, but feeling wise, mental wise, I was even 20 years younger, like than my August 2013 state of mind and state of health. So I said that what can I do about it? So I went on to a path from 2015 to 2017. I went on a path to certify myself and become a certified fitness coach. So I understood the science behind fitness, and I got the best in class certification called the American Council of Exercise, which ACE, which is the best in class certification on fitness. I did that, and I did a lot of other courses, which I won't go into detail, but I became a fitness coach for specifically for women, working women who want to gain back their health and stamina after pregnancy. And I used to run group fitness classes and personal training classes. And that's what I was between August 2017 and August 2019. I put that picture in because I completed one very interesting certification on Pilates during that time, and this is a picture from there. So that's a memory which I have. So this was my life from 2013 to 2019. And in fact, in 2020, when COVID hit, I took all of my fitness coaching business online, and I started supporting people through group fitness classes and personal training classes online. And by the way, this is my parallel passion. I am also a leadership facilitator, and I run a training organization along with my partner, my husband. That's called Tinker Learning. So all of that was going on. And bang, in 2021, which is last year, August 2021, I was diagnosed with breast cancer. I felt lump in my breast, which was not going away. Even I tried to see if it was my cycle related, my period related, but it didn't go away for almost 2 months. And that's when I consulted a gynae and Dr. Rupa Ghancha from Apollo, who pointed me to Dr. Srinivas Juluri, and my journeys of breast cancer, surviving and warriorship started from there. So I think this slide took more time, but I just want to say that if you see these pictures, it's a journey of transformation of mind, body, spirit. And overall, over the period of the last 10 years, my body, my mind, my soul has seen a lot, a lot. And if you reflect, each one of us have had such kind of transformations only if we reflect, or we might be lying at the brink of an opportunity to have these kind of transformations. So whatever levels of careers you are at, I have a mixed bag here. Some of you are just starting up in your career in the nursing field, in the medical field. There are others who might be at the mid level of your career and everything. So even from a career perspective and a family perspective, always think about transformation. What more can I add to my umbrella from a education perspective, from an experience perspective? Because if you see my timeline, both from education and experience, I have moved leaps and bounds. Of course, the last experience I could have avoided. I mean, if I could have avoided that experience, but it was not in my control. But yes, education and experience changes us and transforms us. I think, how many of us agree with that? Yes, no, maybe. Okay, awesome. Anyone wants to share at this point? Anyone wants to share any one life experience? If you can share in 30 seconds, which has transformed you. It's okay to share it in a very rough way. I know we are not prepared. Any life experience or education or experience which has changed you or transformed you. Anyone? Yes, please.
30 seconds. She has given me time. I know this might be several times I have taught to my students. So I have seen the way my dad was, he was suffered the way he has. As you said, my mother, I lost at the age of 36. She has 36. She is a CA colon. And I was the first, third year nursing student. I was so blank. I couldn't able to take that as a daughter, because even though irrespective of I'm a medical practitioner, that time I was finished by nursing, I was into first year born period, I couldn't able to take up. So I have seen that time. So this is not the way how I have to lead. I need to know about more how much sufferings will be done through cancer patients, and a lot of transformations happen from that point.
Yes, yes.
Thank you so much.
Thank you for sharing a personal story. It's important to learn from all. Thank you for sharing. Okay, so my first lesson in August 2021, I was this. These are pictures from last year, me having fun with my children and me having a nice pedicure on the left. And then, of course, I got diagnosed, and this is my day of just the day after my surgery. After I don't know, 32 or 42 hours, I had my first meal. That's a picture from there. So I think my first lesson is that fitness not necessarily means wellness. I was at the peak of my fitness. I was doing really well. I was eating well. I was exercising well. But wellness is a very holistic term. It includes a lot of things: sleep, stress, and emotions play a very, very important role in wellness. And through my last year of journey, I've realized that um, if we are really wanting to be holistically well and not just fit, we need to focus on all of these components. We might look the best, we might eat the best, but if we don't sleep at least 7 to 8 hours a day, if we don't generate positive emotions in our body every day, which leads to a lot of hormones, positive hormones being triggered in the body. I will not go into the science of that. These are a group of yeah, nursing medical science practitioners. But yes, the hormones, oxytocin, serotonin, everything gets released in the body because of the positive emotions we demonstrate. So emotions play an important role. Sleep plays an important role. Hidden stress, stress from traffic, stress from long hours, stress from relationships, anything could be acting on us, and it could be an indirect, it could have an indirect impact on our health. So obviously I went back and analyzed on what are some of the parameters I can improve in my life. So yes, I was fit, I was the fitness coach, but still there was something missing, and that's why the cancer happened. So my biggest takeaway is that do everything you can do, put your might to all of these parameters, because there's only one life. We have only one life. It is about living it to the best of capabilities, and all of these parameters weigh equally, if not more, right? If we it's like a scale. If we put too much on one side, the other side gets imbalanced, right? So life is also like that. We need to be able to place enough and more importance to all parameters of life. So I'm sure it's a constant reflection for all of us. How can I improve? Am I sleeping well? Am I taking too much stress? How can I let go? How can I relax? How can I be more with myself and interact more with myself than just be concerned about the environment, living internally one life inside, and then that gets emanated outside, right? So that's my first learning. Okay. This experience had its own ups and downs. If someone is diagnosed with cancer, any form of cancer, the first thought is, am I going to live? Am I going to be alive? But yes, medical science has made so many advancements, and we have such wonderful institutes like Medicover, such supportive doctors and nurses who support you. But at the same time, one big lesson which I went back is that life is just like a book. Like, imagine reading a mystery thriller. When you read a mystery thriller, there are some ups. One chapter has some ups, and then they leave you there, and then there are some downs, and then there are some ups. There are so many twists and turns in a mystery thriller, right? Similarly, in life, we have all these chapters. There are some chapters which are very rosy. You get married, you get kids, you have the best of life, and then there are some other chapters where things, uh, life throws you these stones. It wants you to catch these stones and make the best out of it. So I think if we accept that life is a book, we will be able to deal with the challenges with more grace, more optimism. Challenges will come in everyone's life. Many of you are nodding your head that challenges comes in everyone's life because you've seen challenges, or you know that there are many more challenges paving your way. So challenges will be part of all lives. The more we accept that life is like a book and it's not a rosy picture, and all chapters will have their own purpose in our life, right? It's like a pack of cards. When you play, how many of us play cards on Diwali or generally? Okay, even in fun. It's not about betting. I mean, in fun. If you play cards, you will relate to this, that when you are given a pack of, you are dealt with a pack of cards or a group of cards, you have a choice. Now, you could not control what came to you. But if you play those cards, you take the risk. Whether you will win, whether you will lose, we don't know. But yes, you took the risk. But if you pack up, you don't play, you never know what you could have encountered and how much you could have won, or what kind of a fun experience that game would have been for you. when you played it. So yes, I mean, I know that a lot of people, when they are diagnosed with cancer, it is later stages, and there is a lot of depression which happens. Some people are not able to take it, accept their diagnosis. But I think the way I accepted my diagnosis is, I've been dealt with these pack of cards. Can I change it? No. Is it under my control? No. But what I do next is absolutely under my control, right? So I share here a picture of my first chemo. This was in September, 6th September, where I started writing my journal, and as you can see, the book, my journal diary is titled "Be Bold" or italic, never regular. So I feel that it's all up to us. The choice is up to us on what we do next. Okay, am I boring you? No? Yes? You can say yes. Okay. All right. Thank you. Okay. So, one big lesson which I learned. So hair, I think it's a very sensitive topic with all cancer survivors, and many of you are nodding because you've seen people cry over hair. I'm no different. I'm also a human being. So I just want to quickly share a story, and I'm challenging myself to share this story without having a tear. The last few times I've shared this story, I've had a tear. So let me see if I can do well this time. Okay, so actually I thought that I will lose hair in a couple of weeks. In my estimate. So I thought that I've always had hair like this much, and I've never tried a short bob style. So I said this is a great opportunity. I'm as it is going to lose hair, so let me try a bob style. And then of course when I start losing, I'll go for a full shave. So this parlor I went into with good hair, but some slight strands were falling, but I did not have the indication that the journey of falling will be so rapid. So when I went in and he put a comb into my hair, a bunch of big hair came into his hand. So he said, "Ma'am, I'm not sure how to give you a bob cut because you are already losing a lot of hair. My humble suggestion is please go for a shave." So within a matter of 30 seconds, I came into this parlor visualizing a bob hair. And actually, I played a game with my friends. I have a group of friends. I sent them a couple of hairstyles from Preeti Zinta, from a couple of Hollywood actresses, saying that all of these have these bob cuts. Which one do you recommend for me? So I played a nice fun game so that I could make the process enjoyable for myself. So everyone voted for Preeti Zinta. Go for Preeti Zinta kind of bob cut look. So I went and showed this picture and said, I want this haircut. Give me this haircut only, nothing else. So he started off, and then all this happened. So within a matter of 30 seconds, I had to make a decision. And what decision? There was no decision to make actually, because he said, "You're losing hair. It's better to now shave it off." So I went for a complete shave off. That's my picture from that time. So that's a before after that long hair and short one. So actually, because it happened in 30 seconds and I did not get time to accept this change, I then went and invested in the most expensive wig. I don't have a picture of that. I missed it. But the fun thing is that, someone told me that, go for a wig of a bob cut so that, your expectation of a bob cut will be there. So I went and purchased the best quality wig, and I wore it exactly for 30 minutes. I could not connect with it because it was not me. It was something artificial. Um, and it's lying there with me. In fact, I have plans to just donate it to a cancer institute. By the way, all that hair also, I donated it. I tied it up in a ponytail and went by the specifications of what is needed to make wigs for cancer patients. And I donated my hair. So the interesting thing is that life is the best teacher. Nature actually is the best teacher. So over a period of time, once I started becoming accepting of my new look without a wig, without any scarves or masks or anything, one day, actually October is the season of fall, right? You see all the trees and the nature having so many flowers which are strewn on the ground. In fact, in my community, there is a very beautiful pink tree which has these pink flowers every day, which fallen on the ground. So I used to go for my walks every day. And one day when I saw those flowers, it clicked to me that my journey is also like the seasons of change. When you look at fall, all the trees and the flowers and the fruits and the leaves have a purpose. Once the purpose is done, we see them falling on the ground and new development happens on the tree, right? The tree is bare for some time, but then new leaves, new fruits, new flowers come in. So everyone in that it's like a symbiotic relationship. Everyone on that tree, every particle on that tree played its role completely before it gave off. So I thought that my hair served its purpose. It served me for 40 years and now it has served its purpose. And the reason it has fallen is because there is new development coming in this body, in this soul. And I need to accept it with grace. I need to look at the signs which God is giving to me. And that's what I did. So that's the season of fall for me. By the way, I've written some blogs on these topics on each of my journeys. In case any one of you want to share it with any cancer survivors, not just breast cancer survivors, please feel free to ping me. I can share my blogs. In fact, a couple of members in these teams who have been regularly in touch with me have the links also. So that's the lesson. Okay, so that's my 8th chemo session. The reason I put this picture here is because chemo typically is difficult for everyone. There are a lot of side effects. Everyone goes through a lot of side effects. But I tried to tackle it with as much grace and strength and perseverance as I could. This particular day, I actually stayed in the hospital from 10 a.m. to 10 a.m. in the morning to 1 a.m. next morning for chemo. I I think it was the toughest day of my entire cycle in the hospital. Lot of things kept going wrong. There are some days when things go wrong and then they go wrong and wrong and wrong, and it's a loop of things going wrong. On those days, you just need to say, today is not my day, and let this day pass, and tomorrow will be a brighter day. So I think on this particular day, I cried a lot. I remember crying a lot because when you are in the moment, sometimes you are not able to have the grace to move on. When you're in the moment, you're like, I'm here, I have little children waiting for me back at home, I'm not feeling good. And why is it happening to me? And sometimes when things are not under your control, you don't understand why things are not happening as the way they generally happen. So my typical chemo timings are 11 a.m. to 5 p.m. So if I come at 10 a.m. and I go back at 1 a.m. in the night, it is an elongated thing. So for a patient, it's crazy. So I won't go into why things went wrong. Couple of things did go wrong, but that day gave me a lesson that challenging days will be there, and some days will be just will full of challenges. You will keep looking for a ray of light, ray of hope. It may not come, it may come, you may be lucky, it may come, but on those days, perseverance is what makes a difference. Am I able to sustain, am I able to persevere through that challenging day? So how many of you agree? Nurses will agree, right? Some days are very, very challenging. Yes, I have seen, doctors will agree. So many hours of staying without food, and surgeries after surgeries, and patients, looking at patients and their outlook. So yes, challenging days. So for me, that day taught me that lesson, that look for the ray of light, but if you don't get it, still accept that day. Say this day was meant to be like that, but there will be another day, which is tomorrow, which will be better. And I have to stick around. I have to stay with myself. I have to persevere. Yes, no. Okay, I see smiling faces. Okay, so on this one, I think I have to stay with the mic, so I'll stay here, but I like to walk around generally. On this one, I just want to share. Okay, thank you for the flexibility. Okay, can you hear me? Okay. So on this one, I want to share that there's a book by
Stephen Covey, which is called The 7 Habits of Highly Effective People. Anyone has read that book? Or anyone has seen a video of Dr. Stephen Covey? Okay, even if you're not into books and you say, oh my God, one more management lecture is coming my way, someone is going to talk about it. My huge recommendation to you is, even if you don't want to read the book, you're not a book person, go just type Dr. Stephen Covey on YouTube and watch a 5-minute video. That will give you an entire gist of what he says. So because I am a leadership trainer and I am a certified coach for 7 habits, I could relate to this philosophy when it happened to me. I think what he says is that situations will happen to everyone. Some of these situations are not in our control. My cancer was not in my control. I actually, by the way, don't tick mark into any of the risk factors for cancer. So it was very difficult for me to accept that when I don't tick mark on any of the risk factors, why did I get it? But those risk factors are just suggestive. Beyond this also, you could get it. So when I couldn't, for the first few weeks when I could not accept my diagnosis, I went back to this model by Dr. Stephen Covey, where he says that some situations will not be in our control. But what is always in our control is our ability to choose our response. So, you might be hit, you might get cancer, you might get illness, you might have the toughest of the times, which are not in your control. But smiling through those responses and accepting it as a part of life, just like I said, it's a book, it's a pack of cards, is that ability lies with us. The ability to smile through a storm lies with us. Now, why do I say this again and again is because the moment we realize that this choice is mine, choice of my response is still with me, that freedom is still with me, it opens so many possibilities. The moment I say, I'm not in control, I cannot do anything about it, then you go down the negative spiral because you continue to believe that you are not in control. Only the nature is in control, the situation is in control. Why this is happening to me? So you go down that negative spiral of why this is happening to me, versus, okay, this has happened to me, what can I do about it? How can I move forward? So I think that is the ability to choose our response, the ability to smile through a storm will always lie with us. So I think it's a great lesson, especially for all of you in this field, because you see so many challenges and you have these days. But smiling through these days and giving your best self to your patients is something which can help you create your own brand. So why would one nurse be different from another nurse? Why would one caregiver be different from another caregiver? Is because of their personality, right? All of you might have the similar level of education and certifications, and that's why you got into Medicover. But what differentiates you from someone else, your peer, is your ability to connect with people, your ability to smile through these storms, and for you to flourish and shine through in your personality, right? So I have been lucky. I don't know. Suman is not here. He's here. Oh, so Suman, Nagamani, and I may be forgetting some names. These are some great people I have met in Medicover because they have smiled through my challenges. Suman particularly has always come and done some small talk with me to distract me. Whenever he sees me stressed, oh God, she's getting stressed, he'll come and just do some random small talk and distract me. And I think this is a great ability. I think with long working hours, which you all give, just coming and saying hello to your patient, smiling and saying a few words, empathizing with your patient can take you long ways, in building a relationship and building your own brand as a nursing professional. And I firmly believe that there are a lot of people in the market who will be your competitors, but you can create your own niche through your personality. If you have a distinct personality which you share with others, others will remember you for that. So I think that's important lesson for all of us, including me. I keep thinking, how can I improve my connections with others so that people remember me and recall me in a positive way. They have a smile on their face when they talk about me or they remember my name. Okay, so I just want to share that I have, through my journey, I have just tried to keep connected to my passion. So I love baking. Baking is my stress buster. So on the left, that's me during my cancer journey. This is the cake for my 9-year-old daughter. She always wants me to bake cakes for her. This cake, why I share this memory is because she said that she wanted 9 of her favorite chocolates on the cake. And I think during my journey, I found this to be a fun challenge to engage in, how to get 9 chocolates on a cake. So I made it happen. And I think it was a great milestone for me to celebrate. I enjoy nature and walk. Second picture of me is enjoying nature. I love to dress up traditional, formal, casual. I love to dress up because dressing up helps me to warm up to the fact that I'm still alive. So, next few pictures are me in nature. That last picture, a middle picture of me in that black kurta is last Diwali. So that was this day I did my treatment and I was not feeling too good, but I was invited to a Diwali party at a friend's house. I decided to go because I thought it will be a good distraction for me. And even if I'm not able to stay for long, I should go. So I went and I had a great time. There were some games and, everyone was trying to pep me up. So I think it plays, your attitude plays a very, very important role in every situation. So live life because life is in the present moment. We cannot, someone used to tell me that how can you be so brave and smiling through your journey? I would have waited till next year before doing this, doing that. They will count things which I'm doing and they say that I would have waited till next year. So I very clearly say I don't want to wait because I don't know what is going to happen in the next minute. I will do what I can to the best of my capabilities today, because today is something which I cannot change. Past is something which I cannot change. The capability I have is to make my today better so that my future becomes better. That's how I believe life is. Okay, so I had a profile on Instagram which had some 300, 400 followers. It was a fitness profile. I used to share fitness videos to inspire people. I changed the name. So this is my current name. It's called Harsha_win breast cancer. And I started posting about breast cancer awareness because I believe that I was struck by surprise. And there are a lot of women who ignore the signs. They don't listen to their body. And it is so important to spread awareness about breast cancer. So my profile is a mix. You can follow me. You can actually suggest my profile to your patients because the only intent for me to suggest this here is not to gain followers, but I really believe that there are a lot of women in India who do not have any kind of an inkling on what their bodies might be going through. There are so many people I meet who have never heard about mammograms, who do not go for checks, pap smears, any checks. So I keep talking to people, and I thought that social media is one important way to spread awareness. So both through Facebook and through Instagram. Instagram now more because a lot of people are quitting Facebook and joining Instagram, and most of the people love to watch stories and reels on Instagram. So I'm trying to adopt that method. I wasn't good at reels, but yes, this last 1 year has taught me a lot. I've made some reels. I'm just going to share this. This is me and my daughter. And okay, I have to do it from here. So my profile is a mix of some fun stuff. This reel got a lot of likes, so I thought, let me share. I'm not a dancer, but she's a dancer. So I try to dance with her. I think I should not talk when this is on. One second. This particular video, the right-hand side, the reason I want to share with you is I made a very simple video. I liked a tune on Instagram and I made it. I never thought that it would reach this high. But this simple video where I'm trying to bust breast cancer myths, and I put a nice caption, I described the breast cancer awareness myths. It suddenly went viral and it has some 19,000, 20,000 views. And my followership increased because I think a lot of breast cancer survivors followed me, though with private profiles. Many breast cancer survivors have private profiles, so I'm not able to go view their profiles and help them out unless they reach out to me. So, which is fine. Everyone has their own, method to stay private, and I respect that. But I want to share this video with you because of the fact that sometimes we might just drop a stone in the ocean and feel that who will see? But a lot of people on social media might be watching us. And even if we can do a little bit to spread awareness, we should do it. So it's in the reel format, and that's why you'll have to go and read the caption to know more. But somehow a lot of people shared this reel and hence it went viral. And after that, I got 3 or 4 people contacting me on private messages. And then some of them found my number and WhatsApped me. So I think through that, I was able to reach the next step, which is actually the Win Breast Cancer India Hub. So I decided that one of the major reasons why I got cancer was that I was on a fitness path, but I could go into a niche in fitness. And now my niche is I want to help breast cancer warriors and survivors to be better in terms of their health, their fitness, and their nutrition, and to recover well through their journey. So I know that the medical treatment is one part of it. There is surgery, there is chemo, there is radiation. But there is another part, there is an entire whole ball game of wellness, which can help people to cope better with a diagnosis as harsh as breast cancer. So I have opened this hub, which is called the Win Breast Cancer India Hub. As of now, I'm running complementary classes, fitness classes, and nutrition sessions for breast cancer warriors. I have about 30 women from age groups of 26 to 89 who are breast cancer survivors, who are part of my hub. And, we work out together. We talk about fitness. We talk about nutrition. We talk about cancer wellness. We talk about emotions. We talk about acceptance. We talk about everything a breast cancer survivor goes through in their journey. And I think I missed this kind of a hub in India. There was nothing in India. I accepted and joined a couple of groups and Facebook groups and links in US and UK. But of course, US and UK, the medicines they use, the terms they use, the kind of supplements they use is very, very different from what we do in India. So I used to go read those groups, but I was not able to relate to a lot of that stuff. And that's when I realized that there is a gap. Maybe I don't know. I searched a lot on Facebook and Instagram, but I didn't find any kind of a hub like this. But I think that even if there is something great, I thought that I could start something and slowly it will grow. If you keep focusing your attention on something, slowly and steadily it will expand. So I started with some 5 or 10 members, and now I have 30 members in the group. So if there is anyone who's a breast cancer warrior, who's currently been diagnosed, going through treatment, has finished treatment, but could benefit from some wellness tips and are open to some wellness tips, you can feel free to forward them to my page, or they can even WhatsApp me. 5, 6, 7, 8, 9, jitni power. So this is a very small clip of the kind of work I do with them, because many of these patients have been have had repeated diagnosis, so they are not able to get up from their chairs. So instead of doing normal strength training sessions where they are jumping and kicking, which is not possible for a breast cancer warrior during their treatment, I have modified, I've customized the programs to suit their requirements. And that is what is the need of the hour. Everyone who goes through a cancer diagnosis, specifically a breast cancer diagnosis, needs to keep active and keep moving and not be on the bed. The more people are on the bed, the lesser will be their recovery. And I think Dr. Ashwin will agree with me. Recovery is dependent on your fitness, and it's okay. You might just say, I will walk for 10 minutes and that's my fitness routine for today. But you need to do something. That's what I want to share with people, that on a daily basis, movement, food, mindset, everything needs to be in line for your recovery to happen faster. So that's what this Win Breast Cancer Hub is about. Okay, maybe I am losing time. I will take the last 5 minutes. So in the end, I just want to share that my story is like the story of an eagle. Anyone knows the story of the eagle? Yes, good, good. You've talked about it. Do you want to talk about it?
Eagle, it will fly over the sky, not under the sky. So when all other birds will be flying under the sky, this is as, and also it will lose its wings and it will go to other level, and it will fill their wings with the new wings. It will come back. And yeah.
Thank you for sharing. Okay, so yes, very quickly, for the ones who listen to this, eagle is a bird who has a lifespan of 70 years. The only bird who can stay up till 70 years. But to stay up to 70 years, it actually has to take the flight of rebirth. And actually that happens when it is 40 years. So I related to the story because my breast cancer diagnosis happened when I was 39 and a half years. So actually almost 40 years. So it is a very tough call. The eagle can decide that it's going to die, and that's it. Or it can decide to isolate itself, go at the peak of the mountain, and it actually loses its wings, its beaks, its claws, everything. And slowly and steadily, it rebuilds everything from scratch. And then it stays for another 30 years or more. So each one of us will go through this time when some transformation is happening, and tough life gives you or shares with you a pack of cards which is so tough. But what we do of it, as I said before, is what will change us. So I think that's my flight of rebirth. And to kind of remind me of my 1-year journey, one last video, because August 2021 was when I was diagnosed, and we are in October 2022, which is 1 year and 2 months. So one last video from my side. Okay, and I had this one slide, which I think we already spoke about though. For all of you, I just feel that you may be already having these characteristics, but if you think that there are some things which you can take back, and these are just very few humble suggestions from me, I think in your role, you need to be very, very proactive to make sure that your clients, your patients have the best time, because they are going through a tough time and they will still need to be here with you. They will need to come for these chemo sessions, for these radiation sessions, for surgeries, post-op care, everything. So at this point, your duty, as if I were in your place, I would say your duty is to be as proactive as possible and make sure that their wait time is minimized, right? Stay as cheerful as you can. I know the job is tough. You see patients struggling and coping every day. But if you can, try and stay cheerful. Have some conversation. Don't just do your duty. Okay, come prick me and go. Have some chat, have some conversation. And I think that's the lesson I learned from Suman. He always used to come and have some conversation with me so that he could distract me. Be empathetic and anticipate the needs of your patient. I think you must have had this training already, but I believe that if we are able to anticipate what the next person needs and we are able to give it to them beforehand, anticipate that. It's a very little thing to do, but it can really make or break the day of your patient. Random acts of kindness. Do something which is kind, which just helps the other person. And minimize the wait time for your patients, because the lesser they are in the bed in the hospital, the better it is for their wellness, their mental and physical wellness. So I think with that, I just want to say thank you so much for listening to me and nodding through and smiling through my story. And I hope that I'm thankful to you for listening to me, and I hope that we can keep connecting in future as well. Thank you so much.
Yes, sir. Now, time is given over.
Yeah. I really would like to thank Mr. Hashi Nagi. Really, when we asked for breast cancer survivor, just give up some, enlighten some words about your journey. When she is trying about to correlate entire her story, really, it was like 1 hour movie. Astonished, like my nurses, I've seen them in off the screen, and people were messaging me personally. It was so amazing, Hashi. You have inspired many people with your talk shows, and what kind of abilities you overcome and what kind of challenges during your treatment. When you speak about Suman and Nagamani, my goosebumps has come when people were talking about nurses. The Suman was taken very good care and Nagamani was attended very. Usually the people will talk about all the time doctors, doctors, doctors. Okay, I'm not against anyone in this group. Please, sorry to forgive me. So no, when nurses were applauded, I always tell same thing. Like, when whatever treatment you do for the patient, just go cheerfully, and whatever problems you have inside, don't show in front of the client, and you have to be cheerful and talk to them. Don't do that. Even they doesn't know that you are giving injection. That kind of, you have to engage the patient and make them fun, and they should not feel that pain. That is what more important, especially when we are dealing with cancer patients, and we need to remember these marks, what ma'am said. I once again thank bottom of my heart. I think my nurses are inspired a lot, and lot of motivation you have given. What all abilities they need to prove. They have every nurse has their talent, but they have to have unique talent, so that you have to overcome. So what ma'am suggested, that you need to follow your finger steps. Thank you so much, Ms. Hashi.
Okay, so I just want to share that my examples from the nursing staff was also because I was told that the nursing staff is going to be the audience today. Dr. Sadvik is here. I think he has played the most critical role. Sarita is here on behalf of Dr. Srinivas Juluri. Dr. Ashwin is here. All of them have played a very important role, from surgery to chemo to radiation. I think, and I've said it multiple times, this hospital has saved my life. Each person who has connected to me and interfaced with me has left an indelible mark and touched me. And because of all of you, I'm able to stand up here and talk about my journey because of the positive experiences the hospital has given to me. But having said that, the reason why I shared those slides and the lessons is because even through the best of journeys, there is always a lesson which we can learn. And I think collectively, all of us, believe in the fact that we can take away something from each life lesson. As I said about the book, about the pack of cards, that's what life is. So I think thank you to everyone for making this journey successful for me. And thank you is a very small word. Everyone knows Dr. Sadvik has always been with me and he's supported me. In fact, the first person to join my Win Breast Cancer hub on WhatsApp is Dr. Sadvik. Despite his busy schedule, he joined the WhatsApp group, and sometimes he recommends and gives feedback also on the suggestions I make to the different members in the group. So thank you, everyone.
Thank you so much, Ms. Harsha.
Once again, thank you, ma'am, for sharing your inspiring life lessons with us. Now, Swati ma'am will hand over token of appreciation to Harsha. Once again, we'll give big round of applause for Ms. Harsha that she shared her valuable life lessons with us, and she motivated us very strongly. She has um, like she's a big role model to all of us. Then how we should be. She's a big life lesson we can adapt from her, learn from her. She has created awareness more than what we are doing. Like we just talk to the patient, we do until we are on duty. She has taken more effort and dedication, even though she is suffering. She has come forward to make awareness and motivate others who are suffering just like her. They might remember her for lifelong, their families. She has done a great job in her suffering. Even though she's suffering, she has done great job to support the people who are suffering with breast cancer. Shall we all give her a big round of applause? Now I call upon Dr. Sadvik to hand over a token of appreciation to ma'am. Shall we all rise, please?
Thank you for all your positive vibration you have created over here, ma'am. Thank you. Now I am inviting Dr. Ashwin Pandit. He's a surgical oncologist, and he has an experience of 2+ years and the experience areas are gynec oncology, head and neck oncology, and breast oncology. We are very happy to invite you, sir. Please. Thank you.
Thank you for inviting me. And that was a very inspirational talk. I would like to do one correction. She had cancer, she didn't suffer. Okay. She didn't suffer. That is the difference. And that is what we need to teach everybody. Okay. When I was in Yashoda, there was one question which every patient used to ask. Sir, after chemotherapy, baal jhad jayenge na? After chemotherapy, I will have a lot of pain. So what I used to do is I used to connect them to my old patients. And I was looking for such a platform here, and I found it after 2 years. I mean, I'm so thankful to you, and I will definitely refer my patients, our patients in the unit to you. So that we need to create this positive environment. And as I said, you being diagnosed with breast cancer does not mean you need to suffer. And you are a living example for that. Thanks for that. Okay, now let's come to the topic. Post-op management of breast cancers. So this forum is mainly for, I was told that it is mainly for sisters. So I'll have directed questions, and directed questions will be towards a set of sisters, okay? Because few of them I know will definitely answer. So I've got two pictures here, one on the left, one on the right. So who can tell me the name of the surgery of the picture on the left? Towards left. I said I'll choose the sisters, okay? So this is not to be answered by any sister who works in the OT. So anyone? Yeah. Bolo. Stand up, stand up, stand up. MRM. So it is called a modified radical mastectomy. The picture on the right. Very good. That's your gift. I'm sorry. So a modified radical mastectomy is removal of entire breast. Okay. So you remove the entire breast, you remove the entire axilla. So what is the name of the surgery? Not you, Sri Lakshmi again. Anybody else? The other one. BCS. Sarita, you're not a sister. Anyone? No, sir. No? BCS? Okay. Sarita will handle it. I'm very bad at throws. Hey, you Enkala. So basically, post-op management involves two things. One is management of a patient who has undergone MRM, and second is how to manage a patient who has undergone BCS. Okay. Chocolate is just to keep you interested. So POD 0. POD 0 is what? On the same day. So what are the things the patient has undergone surgery? He has come into a surgical ICU. What are the things as a nurse that you need to monitor? So the first thing that you need to monitor are vitals. So what are the vitals? Temperature, pulse rate, BP, respiratory rate, and saturations is not a vital. Okay. Pain score. Okay. So on the day 0, the most important thing which you need to see is pulse and pain. You getting this? Because pulse rate can rise because of bleed. It can rise even because of pain. The next thing you need to see is drain color. I'll be showing you a few videos. Sorry, one video, not a few. And then the NBM status. So any patient who undergoes a mastectomy or undergoes a BCS is done under anesthesia. So we need to keep the patient fasting for 6 hours. If not, what will happen? Any idea? Okay. You keep them for fasting for 6 hours. These are the things that you need to watch on post-op day 0. Okay. Next, coming to the post-op day 1, recheck their vitals, recheck the drain color, give them diet. So as I told you, you keep the patient fasting for how many hours? 6 hours. And after that, you start the patient on liquids. So by the day 0 night, the patient should have had their dinner. And I apologize to you, ma'am. You had food after 32 hours. I'm really sorry about that. So she should have had dinner on the night, on the same day. Okay. We have delayed her dinner. We owe her that. Okay. Okay. And then we teach them about shoulder exercises. and drain care. So I'll be touching on each of these topics. So how do you empty the drain? This is a very important thing. I have seen sisters seeing the drain like this and telling, 250 ml. hai." Seeing the drain like this, it is 300 ml. I'm telling you, nobody can tell the quantity of drain just by looking at the back of the drain. Okay? There's a proper way in which you need to empty a drain. There's a proper way in which you need to measure, and there is a proper way in which you need to put the drain back. I mean, connect the drain back. Okay? Yes? So we have a drain here. Let's see who wins the chocolates. I need somebody to come here. Show me how the drain is opened, how the drain is measured, and how the drain is connected back. Who will do that? Not you. Anyone? If you don't come, I will select. There are pros, you know, they are the ones who teach me. I can't call them. Let me choose. Let me choose. Let me choose. Yeah, I know. That's why I'm saying she's a pro. Come, come. Anuradha, come. Yeah, come. So this is called so basically this is the drain which goes into the body of the patient, and this is not there. This is used for insertion, and so just show me how this is charged. So one thing, come nearer. Okay, I'll also come. Give me a mic. So this is how. No, that's fine, man. Absolutely fine. What will you do with by learning drain care? You have taken care of many other things. That's absolutely fine. If you can, if you want to offer, you can. Yes. Thank you. So you need to make sure that did you find the other one? Try to separate this from this. So that part of the drain goes inside the body of the patient, and that is connected to this. Okay. So there are two openings. Two drains have got two openings, and both of them are connected, and that is connected to this. One thing that you need to always make sure is that the patient, when the drain is connected to the patient's body, it is always in this position. It is always compressed, not even in this. It's actually expanded now. It needs to be compressed. Okay. So how do we open the drain? That is what Anuradha is going to show us. So the first step is to open the clamp, clamp it. And then you disconnect it from this. And then when this is open, you empty it into a bowl. And then whatever you have emptied, please measure that. You understood? So the first step is clamp it and then open it, empty it into a tub, measure it. Okay. After measuring, putting back the drain is also very important. So the first step is to compress it completely like that. After compressing it completely, reconnect the drain. And in the end, do not forget to open the clamp. Got it? Yes? Okay. Now a question. Chocolate, for the chocolate sake. What does this green color, orange color, red color mean? Rohita, don't answer. What is staff? Don't answer. I have questions for you, okay? Okay, green is bile, good. Blood, yes. and yellow is serous. You are right. Take this. Take this also for being wrong. Okay. So these are the number of the drains. 14 number drain is green in color. Okay. 16 number drain is orange in color and 18 number drain is red in color. Got it? So as the number increases, the drain size goes on increasing. Got it? The same holds true even for the Riles tube. A 14 number Riles tube is what color? 16 number Riles tube is what color? Group lo andar cheptunnaru. Nobody wants chocolates. What is this? Red color Riles tube is what? Sorry, 18 color is what? Okay, thank you. Thank you, Anuradha. తెచ్చినా సార్ అందరికీ తెచ్చిన ఈ మాట వస్తుందని నాకు తెలుసు అందుకనే తెచ్చిన I have questions, sir, for everyone. There's a small video. How do I go back? ఈ PPT నుంచి బయటకి ఎట్లా రావాలి? Right. You are on duty and this is the color of the drain. Can you play it back again? Now this mic gives me that freedom to move around. So, David, you are on duty. What will you do? This is the color of the drain. Sir, good thing, sir. Video this పంపిస్తాడు. That is the first thing that you need to do. Inform the surgeon. The first thing that you do when you see such kind of drain is inform the surgeon. Now I give you two scenarios. In one scenario, you are alone, and in another scenario, there are two of you. Okay. So one person take care of the patient, one person takes care of the logistics. Okay. Suppose you are alone. What you need to do is you call the surgeon, inform the surgeon, place two hands, take a gauze piece or a mop, place two hands, one hand in the axilla, one hand on the top of the chest wall, and wait till the surgeon comes or till the bleed stops. You got my point? If you are two of you, then you have the liberty to send for CBP, monitor his vitals, start giving blood, order for blood, reserve blood. You got it, no? Yes. So this is a video from one of our own patients which happened, and surgeon was informed. Huh? No, the video was taken by critical care people. The video was taken by critical care people. Yes, yes. And thank you, ma'am. So that is the first thing that you need to do. What? Inform the surgeon team. Okay. And if you are two of you, one of you take care of the patient, one of you start informing the surgeon, informing others, informing the MOD, arranging things in the OT if anything is needed, informing Mansaka. All this you need to do. Got it? Done? Okay. So, as I told you, it should always be like this and not like this. Okay? Suppose a patient comes back to you and the drain is like this. Then what do you do? What does that mean? If the drain is like that, what does that mean? Positive pressure. It simply means that there is air in the system. Now that air can enter from anywhere. Okay. So Sarita will tell what is to be done. But there is expansion of the drain. It's not clot. Okay. So divide your drain into three parts. Okay. The first part is the part which is there inside the body. Okay. The second part is this pipe. This one. Okay. And the third part is the box. So when you see that the drain is expanding, come in a reverse direction. Attend to the third part first, then attend to the second part, then to the first part. Ante, first see the box. Is there any crack in the box? If the box is broken or if there's a crack, what will happen? Air will come into the box. What will happen to the box? It will expand. Simple as that. So first, look for any cracks on this. There are no cracks. Next thing is compress it and connect it to the tube. But don't open the clamp. Okay? If you don't open the clamp until it is still clamped, but still it's opening, that means there is some break in the box, but you're not able to see it. Are you getting this? So first, see any cracks are there or not. If they're not there, connect it and do not open the clamp. If it is still opening, that means there's a problem with the box or there's a problem with this junction. Okay, this junction has not been put properly. So open it and reapply it again and then redo it again. Dono kiya, still it is leaking. Next thing is you check for the next junction, that is this. This connects to a pipe, right? Most of the times what happens, patient will have a single drain. It will be connected to this. The other one needs to be capped. It is not capped. So what will happen? Air will leak through that and the box will open. So the first thing you check is the box. The second thing that you check is the tube. And the third thing you check is the junction. And if all the three are intact, but still the box is expanding, that means there is a leak from the level of the skin from where the tube is coming out. Then you have no choice. You have to call me or one of the surgeons. We will take care of it. Okay? Done? Okay. So this was troubleshooting the drain. So on day 3, first, second days, I told you what to see. Day 2, usually there is nothing much to be seen. On day 3, we need to do a check of the wound. Okay? Usually the drain clots. So the drain needs to be declotted on day 3. And oh, I think I missed a picture. You need to see how the drain color of the wound is. The wound should be healthy and there should not be any black color. So any blackening of the wound means the wound is necrosing. It needs to be revised and resutured. So when do we remove the drain? Whenever the drain is less than 30 ml. And when do we remove the sutures? When do we remove the sutures? कौन बोला रहा है 14 उधर से some male voice I heard. Aware, you, this chocolate are yours. I will keep it with myself. So suture removal after 14 days. And the most important thing is shoulder exercises. So shoulder exercises, I think you have a session, right? On shoulder exercises by Dr. Sridhar. Yes. So just to make a brief thing, many of them will say, I have a drain, I'll have pain, so I'll not do. No, the thing is, since you have a drain and since you have a pain, you have to do it. Got it? So from day 1 itself, make them do exercises. So main thing is the abduction exercise. They need to raise their hands up and by the end of 7th day, the hand should come up. Okay. So the first day, they'll be able to lift till 30 degrees. So ask them to lift and down 10 times in an hour. Okay. Ask them to do that every hour. Okay. Are you all listening? Okay. Like this, by the end of 7th day, their hand should come completely up. Now, question for Rohita. There is one exception when you should not do this. When? Yes. When should you not do shoulder exercises in a patient who has undergone a breast surgery? Infection? No. Why will infection? How does it matter? Bleeding? No. How does it matter? Till an extent, bleeding is correct actually. Really? This was the only throw which went to the designated person. Okay. So you don't do when the patient has undergone what is called as a LD flap. LD flap is a flap which is taken from behind and we rotate it. Okay. We give an artificial breast to the patient. So the pedicle comes through the axilla. So if you ask the patient to move like this, you may do it violently, the pedicle will get thrombosed. So this is the only exception when you should ask the patient not to do a shoulder exercise. Otherwise, all patients who have undergone an MRM, all the patients who are undergone a BCS must do a shoulder exercises. Okay? Okay. What other care do you suggest to these patients? Sorry, I could not include it in my slides, so you'll have to listen to me, whether you like it or not. What other things do you tell a patient? Dressing, okay. So our protocol is after 48 hours, we keep the wound open, so no question of dressing at all. Bath, yes, very good. Take bath, then. See, one thing you need to understand, our body has two systems to let the fluid go from the limbs to the heart. One is the venous system. The second system is what? कुछ तो बोलो. How many chocolates you want? Lymphatic system. Okay. So the lymphatic system has got stations. Those stations are called as lymph nodes. And those lymph nodes are there in the axilla. So when we do a surgery, we have removed those nodes. So what will happen? This fluid cannot go effectively back to the heart. Okay. That is one thing. Second thing is the fluid in the lymphatic system consists most of the cells which are responsible to fight an infection. You heard, no? WBCs, RBCs. So most of the WBCs, most of the lymphocytes traverse through the lymphatic system and they are responsible to fight the infection. So what has happened? One, the fluid which is there in the arm is not able to go to the heart. Two, the arm is not able to fight an infection. These are two changes which happen after MRM. Understood? So you tell those patients not to put any IV cannulas on the same side. Why? Because if you insert an IV cannula, there may be edema, the edema may not subside. And if it gets infected, then Govinda, Govinda. Okay? Tell those patients not to wear glass bangles. Why? You may get injured. No chocolate for this. If it gets injured, then it may not heal. You tell the patients to apply moisturizer regularly to that arm because dry skin can lead to infection. Okay? And most importantly, tell them not to wear tight clothes because any amount of tightness here, especially blouse, if it's very tight, it can cause collection of fluid and the swelling in the arm. Okay? Done? So the same thing for breast conservative surgery also applies, but the difference is that in an MRM, there are two drains. In a BCS, there is usually one drain. And the second difference is that you need to keep checking this wound, the main wound. There is a chance that this wound will collect fluid because we are not draining it. We don't have a drain there. The fluid will collect there. So you should watch for redness in this wound. Okay? That's all. Thank you. Any questions for me? No? Any chocolates for me? No? Okay. All leftover chocolates for Sarita sir. Okay, thank you.
Thank you so much, sir, for your interactive session and more informative. And thank you so much, sir. Give big applause for Ashwin, sir. Thank you, sir. And any doubts, any queries, you can ask in the chat box. Now we are inviting Naresh sir to take a end of life care session. Naresh sir is a chief Chief Critical Care Consultant, and is also medical care strategies and development and medical staff coaching and trauma care management, testing patients with multiple organ failure and ventilator care, especially patients with ARDS, and well versed with the ultrasound guided interventions in ICU. Thank you, sir. We are over to you, sir.
Thank you. Thank you for the introduction. Good afternoon to all of you. My session today is regarding the end of life care as per Indian scenario. So end of life care usually occurs a patient who has received all lines of therapy when there is no treatment option left for further. So this is a famous physician, Roger Bone. He said, dying can be a peaceful event or a great agony when it is inappropriately sustained by life support. So this is how we look at life. We expect it to just go and go and go on. But what if there is a chronic disease? It might happen to anyone. Unfortunately, medicine today can help recover, but and they can help us to keep comfortable, but sometimes medicine cannot stop the progress of the disease. So when the doctor indicates there is an end is near, the patient finds very difficult. There will be a lot of questions from the patient side. What if I am serious? How long do I have? What will happen to my family? These questions might arise from the patient side. So what does the family think? The family will be also in agony. They have a lot of questions. They will ask, are you sure? Is there anything you can do further? What do we can do further? So the answers will be no for everyone. So we have to be very patiently counseling them regarding the end of life care, because further there won't be any options of treatment left for them. Okay. So the patient and the family must feel free to share their fears and concern with the doctor. So there will be questions. What if my question is silly? There might be doubts in the patient attenders. Whatever I'm asking is a very silly question, or it is rude to ask any doctor any question. Will the doctor have time to talk to us? The doctor knows best. Why should we ask? This all thoughts will happen in their minds. So this is a time for some honest communication. So we should have always an honest communication with the patient, with the surrogatives and the family members. And we should have a collective decisions regarding the end of life. Apart from care, comfort care, end of life care provides psychological, spiritual, and social support. So the objective of end of life care is to minimize invasive treatment and optimize some comfort care for terminal patient in Indian intensive care units by standardizing the process for foregoing life support. It is also define the ethical standards of physician-patient relationship in the context of critical care in India. So to achieve a good health death for any person who is dying, irrespective of the situation, place, diagnosis, or the duration of illness, acknowledge that a good end of life care is a human right. Okay, it is a human right of end of life care, and every individual has a right to be a good, peaceful, and to have a good, peaceful, and dignified death. So what is the physician's approach? So physician's death is inevitable consequences. In serious illness, it should involve three dimensions. One is the medical, one other is ethical, and there is a legal aspect. What is the scenario today? Death from serious illness is inevitable. Despite interventions, technologies cannot save life. All the heroic intervention which has given to the patient will go waste. The family will be sidelined. Death is medicalized. So promises of cure is overestimated. So there will be a lot of conflict and confusion. Somebody says, okay, we will do this, we will do that. Other will say, whatever we do, nothing is can achieve. So this confusion and conflict will be there. So there is some ethical foundation for end of life. The patient decisions are supreme. Always always, whatever the patient decides, it is supreme. We have to obey their decision. The family as a surrogate decision maker. Then there is beneficiaries, the obligation to act in a manner that produces the greatest benefit to patient. Then there you have a premium non nocere, distributive justice like similar case. So there should be no pain, no distress to the patient at any time. Always respect the patient dignity, likes, and the rights to make decisions. Allows the patient to express preferences about the end of life. So it is important to honor the patient wishes. Whatever the wish he is having, we should always honor him. Like he wants to tell some forgiveness to his friend, we should allow him to do that. If he says he doesn't want any life support, we should honor his wishes. If he wants to die at home, we should allow him to go home and die. If he wants to be with his wife or spouse or with his family member, we should allow them. If he wants some priest to help, we should allow them. If he wants their family member to be nearby at the time of dying, we should allow them. So what are the best checklist for initiating end of life care discussion? Advanced age coupled with poor functional state due to one or more chronic debilitating organ dysfunction. Example, end-stage pulmonary disease, cardiac disease, renal or hepatic disease for which the patient has received or declined medical or surgical options. Catastrophic illness with organ dysfunctions, which is irresponsive to reasonable period of aggressive treatment, and coma, where there is a irreversible damage to the brain occur. Chronic severe neurological conditions, progressive metastatic cancer where treatment has failed, post cardiorespiratory arrest where pure neurological recovery after at least 3 days, or comparable clinical situation coupled with physician prediction of low probability of survival. Patient family preference to limit life support or refusal to accept life support. What are the principles of good death? The ability to know when the death is approaching. We should have some physical symptoms well controlled and non-physical needs are met. Right to die in a dignified manner at a place of choice and not needlessly prolonged with artificial means. So we should not unnecessarily prolong his life by putting on artificial mechanical ventilator and inotope supports and everything. Components like pain, and the component should be have a pain and symptom management. There should be a clear decision making. We should be preparing for death, completion of the documentation, contribution to others. There should be a continuum of palliative care. Like healthcare providers often perceive that palliative care is referred to appropriate when patient is dying. So the limiters exclude majority of patients who are not dying, but as poorly controlled symptoms and distress that could lead to abrupt transition of care from curative to palliative care. It is important to consider the continuum of palliative care, which was proposed by the World Health Organization. So this is the pathway of in end of life care. When the patient comes, he is undergone all the screening, he was diagnosed, then he might be a curative, might be in a palliative care, then ultimately you will land up in a end of life care where death cannot be prevented. So there are 6 steps in end of life care process. First, we need to identify to whom to initiate and when to initiate. Okay, identification is important. Then we need to assessment of physical symptoms and distress, assessment of non-physical issues, assessment of communication needs. Then we need to plan. Okay, site of care, what plan of care we can give, review existing care protocol, unnecessary intervention, medication, investigation should be avoided. We should provide access to essential medications. Then we should ensure that adequate control of pain and other symptoms are ongoing through ongoing assessment. Okay, and we need to document. What are the infrastructure needed for this? We need to have a good policy, protocol and everything. We should have a space and staff for this, trained staff. They should be very well educated and trained on regular basis, and proper documentation with special support. Withholding and withdrawing of support. What is withholding? The withholding is not where the consideration decision not to institute new treatment or escalate existing life support modalities. This is called withholding. We are not supposed to escalate or start any new treatment. This is called an act of omission. What is withdrawal? The cessation or removal of ongoing medical therapy is called withdrawal. It is fully anticipated the patient will die following the change in therapy, primarily because of the underlying disease condition. This is called commission. But withdrawing is not officially allowed in Indian scenario. Limiting therapy is ethical. Okay, we can limit the therapy, but we cannot withdraw the therapy. Honest approach to failing treatment, that is called futility of care. Minimize patient discomfort, guarantees the distributive justice, and death is not an intended goal. Futility of care is nothing but intervention should be highly unlikely to result in a meaningful survival of the patient. Whatever intervention is doing, it is not going to help the patient in the recovery. So there are subtypes of futility. One is called physiological futility, quantitative futility, qualitative futility, lethal condition futility, and imminent demise futility. What is physiological futility? Treatment cannot achieve physiological aim. So whatever we are giving treatment, it won't recover whatever is physiological condition. Quantitative futility is treatment that has less than 1% chance of being successful. Qualitative, that merely preserves unconsciousness. Lethal condition futility, underlying condition not affected by treatment, patient might die within weeks or months. Imminent demise futility, the patient will die in future. So these are the subtypes of futility care. Euthanasia, the intentional killing of patient by direct intervention of a doctor for the good of the patient or others that to relieve suffering. But euthanasia is legally not allowed in India. Some of the Western countries, they follow this euthanasia protocol. DNR, this is do not attempt resuscitation. Recently, the ICMR guidelines have given the consent forms regarding the DNR, but legally it is not allowed. Okay. This document is to help and guide treating physician about their decision on do not attempt resuscitation. The intention is not to prolong suffering of the patient and to preserve the dignity in death by avoiding medically non-beneficial CPR while providing compassionate care. So we can avoid doing CPR for such patients. We can avoid CPR. Once they give a DNR consent, we can avoid CPR. But whatever the treatment is going on, we cannot withdraw that or we cannot stop. We have to continue treatment. It is to preserve that mutual trust and respect between the treating physician and the patient surrogates. This document would apply to a patient with incurable disease, only for the incurable disease where CPR is inappropriate. Okay. In only incurable patients, where the CPR is inappropriate, non-beneficial, while applying the principle that compassionate care is integral to the overall goals of medical treatment. Healthcare professionals should communicate clearly about the following before making the DNR decision. DNR does not automatically mean withdrawal or withholding of other life support. Okay. The final decision regarding DNR, where CPR is deemed medically inappropriate, rests with the treating physician responsible for the patient care after informing patient surrogate. The DNR should be subjected to review at regular intervals by the treating physician. Suppose once the patient gives the DNR consent, tomorrow some other relatives come, they want to do aggressively. So we have to listen to them and continue the treatment. Okay. So this is the algorithm for a DNR decision. If this patient is at risk for death or cardiorespiratory arrest in the near future, if no, then we need to continue treatment as deemed fit. Okay. If you think the patient is not going to die in near future, then we need to continue the treatment. If you think the patient is going to die in future, so the question arises, does the CPR has a realistic chance of survival? If yes, CPR should be done. Suppose if there is no realistic chance, then it is no. Then we have a question whether this patient is competent to be informed or consulted about a DNR. Okay. If yes, then DNR should be discussed with in a sensitive way with the family. If no, DNR should be discussed with sensitively in simple consequence by treating a physician. Then we need to follow the DNR steps and take the consent and give only supportive care. So this is the DNR consent issued by the ICMR. I think so everybody is aware we have our consent in our ICUs also. Sometimes we take for few patients such consent. Everybody is aware of this consent. So life eventually ends, but end of life care does not. Okay. Bereavement support helps the family cope and start separate. Whenever the patient dies, so we need to be very supportive to the family. We should give some relief to the patient so that they can cope from the whatever the near ones have died. So end of life care is about never stopping to care, even when we cannot cure. Never say I cannot do anything more. You should never say. Always say I can do something more, but there is always something more that we can do. So never say no. The care with which we treat the dying affirms that our immunity is living. The good physician treats the disease. The great physician treats the patient who has the disease. So this is the Indian Society of Critical Care Medicine has issued some guidelines regarding the end of life care policy. This is an integrated care plan for the dying. So this is the schematic chart of the end of life care. So always early disclosure of prognosis and offer of palliative care should be the first goal. Then discussion to reach consensus with the family, patient family. There should be a transparency of all the process, whatever you're doing, and there should be effective palliative care to be given to the patient. This is the palliative care form from other hospitals. This is a checklist where the aspects of the care should be pain management, comfort measures, nutritional care, spiritual care. Then there should be autopsy or organ donation form. Okay, this is a form we should follow. The conclusion: there is a need to develop law specifically dealing with limitation of therapeutic measures, but there is enough precedent in international law to support such limitation. In India, such law is not existing. Indian law as it stands currently offers sufficient protection to well-intentioned clinicians, so there is no need to practice treatment limitation fertility. Professional consensus need to be built, used as the best protection against use. Thank you. Any questions? No. Family plan. Then also we can have to. When patient is not in a position to say we cannot discuss his wishes or something, if the patient family can come approach us that his wish was. You can allow one to talk. That is the spiritual thing. We have to honor them. Withholding. No, that's why I tell you, it is not a legal issue.
That you told about euthanasia.
Euthanasia, even DNAR is also not legalized. Withdrawal means we cannot withdraw things.
Okay.
Whatever the treatment is going on, we need to continue.
Okay.
We are not supposed to stop anything.
That's withholding.
Withhold. Withdraw means we cannot withdraw anything.
Okay.
Whatever
So
is
in
going
India,
on, we
it's
need to
not allowed.
continue. We can stop escalating things. We can do that. We cannot further escalate things. Whatever is going, we need to continue that same way. No need to escalate further. Means like escalating of antibiotics or escalating of inodrop support or escalating the ventilator support. This we can hold there.
One last question, sir. In the last palliative form, I don't remember what the form was.
That is a checklist.
Checklist. The sixth one was about organ donation or
Actually, it
autopsy.
doesn't apply to us. It applies to the patient who met with road traffic accident.
So
where
my question is, can cancer
brain
patients
death,
donate organs? Can cancer patients donate organs?
No.
Thank you, sir. Thanks.
Now we were taking end of life care consent.
End
So
of life care consent also we need to have some legal aspect.
Yes,
that.
yes.
We should have an ethic committee. We
Yes,
should have
sir.
our own policy and everything. That we need to pray.
Yes, for nursing point of view, like as you mentioned, a lot of rehab therapy is involved. like how you wanted to take over those challenges, like nursing perspective, sir, especially when patients suffering with cancer on ventilator, as you said, like withholding or we can't continue the treatment when family has a lot of constraints and they may have a lot of issues. So they keep frequently they come and ask for the nurses, like how was the patient. However, we tell about the condition, but still they have their own challenges. So nursing perspective, like what kind of rehab therapy and what kind of motivation or some kind of deviation from that, like attendant, because he's literally ill and they will not accept as easy that, especially when patient is on end of life care, and what kind of palliative approachable holistic care they can guide for nursing perspective. So can you suggest few tips?
So basically, the patient is decided for end of life care. So nursing aspect will be give a proper symptom-free, pain-free, proper nutrition, okay, comfort to the patient. And whatever the wishes patient is having, we need to fulfill the wishes. Whatever. If the patient is conscious, which is able to answer. So whatever the wishes you need to fulfill it. If you ask some attenders to be with them, you should allow them.
Yes.
Don't deny.
Some spiritual and psychological support, however, we do, sir. Yeah. Religiously, we can even some mantras, some chanting, yeah, we can allow music therapy. Yes.
Medically, pain, symptomatic treatment, comfort, proper nutrition, proper hygiene care.
Questions more than me, like a bedside nurses, ICU nurses, they may have a lot of questions on end of life care. I think day in, day out, you are seeing. Even my online viewers and offline viewers can post your questions on chat box, because this is very interesting topic. Like each topic is very interesting, but when you are treating, especially it's a end stage disorder, cancer, when patients are suffering with end of life care, so we have a lot of triggers in our mind. I think this is the forum where you can ask your questions. Most bedside ICU nurses, even ward nurses, once we shift from the ICU, they'll be on rehab therapy. Any questions from audience?
So sometimes patient relative know about the patient condition, that the patient is going to be no more in few hours or days. Still, when we go out or come in, they expect some good news, like how is he doing? Is he like
That's what
kind of
proper counseling to the relatives.
so in that
is important.
situation, how can we approach them? What kind of talk that we can have with the relative who is approaching for a good news when the patient is not in a good position?
Proper counseling from the day one itself. Okay. If you tell that suddenly that yeah, your patient is going to die, nobody is going to accept. Okay. So palliative care starts from day one itself. When all the options of treatment is over, we need to plan from that time itself. From that onwards, we should be regularly counseling the relatives that this is the end. This is the end. Okay. We should prepare them. We should mentally prepare them that your near one is going to die very soon. This has to be done from the day one. Okay. Not on the last. Okay. Thank you.
Thank you, sir, for taking up a wonderful interactive session on end of life care. Now, I call upon manager, Mr. Nikhil, manager of Coloplast company, to introduce their product to us. Please welcome him with a big round of applause.
She joined us for ostomy days in the month of July. she came to Kovalam and she has spent 2 days with us, with our company, our colleagues. I want her experience, like how she has traveled and what she has seen and all. Please.
The ostomy days 2022 was a great successful one, and it was conducted in Trivandrum, and in through that conference we can understand the all about the coloplast, like from the starting, what to say, how the colostomy care being taken, and also there many dignitaries came with their own experiences. They explained everything, like their day-to-day life experiences with us. They shared, even they came with every PPTs, like same, how they took care of the patients. The same scenario they took as a case study and they conducted there, and they explained everything very nicely. As well, even they introduced their new coloplast, like sensoromio, everything that is very helpful nowadays to the patients. Through that, while using that colostomy bags, even though they can do everything, like all the activities they can do. So like even they can dance, gym activities, everything. So it was a very good section. So I thank Ostomy for conducting a good section like that. And also you can even attend. It will be very helpful. I enjoyed and I gained many knowledge through this conference. Thank you.
Thank you, Maria, for your sharing your experience. Before I start my session, just I want to ask, like, how many of you are from SICU? And OT? Right? ICU? Thank you very much. And what's please, ma'am. End of the session. Okay, done. Thank you very much. So, what is ostomy first? Great. So today we see all this, like totally few selected few points there, like basics of ostomy and what we do in the market, and complications of the patients and tools which we have in the market, and a diet, and as well as a small quiz. So I'll start with the quiz first. What is an ostomy? Rightly you have said it's an opening. Okay. And what is a stoma? Then stoma, SICU. Any experience, any patient? And OT. Yes, that is stoma. It's a surgical opening of like bowel to the like the wall of the abdomen. That is stoma. Now, like ma'am has some experiences. Like she already like seen a patient, grandma, as well as you have already seen some patients in the SICU and OT. What are your experiences?
Yes.
Yes,
Not my grandmother, my mother. Like at the age of 36, I just finished my nursing third year. I just entered as a new novice. I don't even know, just I have passed from the school. I'm a diploma nurse. Uh, when I was in third year, third year, fourth month, she was ruled out with CA colon, and it is adenocarcinoma stage 4. It's already was late, and initially the doctor said when we diagnosed itself, when we took her in CMC Vellore, initially we took her in St. Anne's, Vijayawada. They have done colonoscopy. The doctor was ruled out. She is has some big mass. I think it must be a cancer. And those days in 90s, we don't have, we have to wait for the marker and biopsy. We used to send for Mumbai for the sample and to get the so I realized, okay, we wanted to take for the best care. So we took her into CMC Vellore in 90s. It was in 97. So there I was really shocked by seeing a lot of patients suffering with cancers. That is my first lifetime experience. I have seen only few patients in hospital where I went Gandhi and Usmania for my affiliations. I haven't seen patients who are really suffering with lot of cancer burst, and lot of there is no awareness on public also how to deal with this kind of stoma. I have personally, when they tried me, the doctor surgical here, they referred me in MNJ Cancer Center, because that time we are from middle class family, and we don't have that much cost effort to deal with the treatment. A lot of radiation involved with colon cancer, and it was almost like we spent those days. My father was spent 10 lakhs for surgery in a reputed hospital, and later they have referred for radiation. So there in MNJ Cancer Center, Mohan Vamshi was told me that he has tried me like how to deal. She was suffered almost for 3 years with that colostomy bag, and those days we never used to get like a permanent bag. We need to change when and where. Lot of time I used to feel, when I used to eat, I took for 3 months break to take care of her, and because she has on treatment, I was taking care. And I evolved very completely, and sometimes I never used to feel like eat because she used to irritate. The bowel used to come into that bag, and it was leakage and lot of plaster. We used to do a lot of dressing, but still there is a leak. And a lot of we don't have this kind of skin graft, as a lot of technology evolved with that. So in my personal experience, she has skin ulcerations and a lot of medical adhesive tape related skin injury, and she was on under treatment. A lot of skin peeling. These all things happen. This is the big rather than heart disease, she went through a lot of pain and a lot of skin septic ulcers. This is what my experience, which I have seen those days. But now when I have seen the coloplast, how beautifully they given, as she said, Maria, her experience, patients were feeling so happy. They're living with normal lifestyle, and they're doing a lot of activities, their own activities, without distracting with that colo bag or colostomy. Nobody knows that actually. Before it was so painful, and people never used to dress up also properly. But the technology was, transformed, and a lot of mechanisms has come. That is my lifetime experience, which I have seen my own mother. Thank you.
Thank you very much, ma'am, for your sharing your experience. It's very valuable. Nowadays, so many patients are facing the same issue of leakage and all. So these are, I have mentioned few questions here. Like normally you will face these questions from the patients in your wards, ICUs, and OT also. OT less chances, SICU and wards a lot. Okay. You can read here. What do I do when I experience skin irritation? When the patient and what you will face, what do I do when I experience skin irritation and leakage? The patients normally ask you, and how can I avoid peristomal skin issues? Rightly, ma'am said she has faced a lot of skin issues. Even in the patients also, like normally they'll face these issues. And how do I prepare my skin before applying bag and all? How often should I empty my ostomy pouch? And what pouching system should I wear? And what's the best time? And what clothes? And what can I eat? These are all common questions you will face in your practice. Okay. So before going into the basics, I want to share with you. We have a Coloplast Academy with us. Apart from sales and apart, we have a Coloplast Academy where we train nurses there, and every year we conduct some activities. And normally, I personally do workshops in our all the hospital, all corporate and government hospital, where I train nurses how to put and how to take care of the patient. Okay, in our ostomy days, we train nurses, we take a few selected nurses. We have this year we have sent Maria to our ostomy days conference. Like every year, we send new candidates to that, so there they can learn and they can implement their experience in the wards and as well as ICUs. So we have seen what is stoma and what is ostomy. Now, how many types of stomas are there? Normally you see in your practice that we commonly see three types of stomas. One is colostomy, one is ileostomy, and one is urostomy. How will you will differentiate whether the patient is having colostomy and ileostomy? How you will differentiate? If suppose I'm a patient, I came to you for the OPD first time. By seeing my condition, how you can say whether I'm having colostomy or ileostomy? Any difference between colostomy and ileostomy? Side. See here, colostomy is on the left side and ileostomy in the right side, and urostomy also in the right side. Now, how can you differentiate between ileostomy and urostomy? Both are on the right side. Then, good. Great. For urostomy, the output is urine, and for ileostomy, semi-solid figures. Stoma locations. Most of the times, colostomy is on the left side, 95%. Ileostomy and urostomy are the 95% on the right side. So the most common types of stomas are rightly we have said ileostomy, ileum, colon, and urostomy, urinary system. Ileum, rarely we will see gynostomy and ileostomy, and colon. Sometimes you'll see transverse colostomy, but most of the time you'll see sigmoid colostomy. And urostomy, the surgical procedure called as ileal conduit, okay, or big bladder. It's a urostomy, we can say. So as per global survey, ileostomies are 30%, and colostomies are 60%, and urostomies are 10% globally. But in our India, ileostomies are more, colostomies are less, and urostomies same 10%. So before going into the basics, I want to share you some pics. Maybe ma'am, she can recall her experience by seeing these pics. After having such a biryani, I know seeing these pics is hard to see, but it's our practice. So it's a normally after immediate surgery or after 1 week surgery, the stoma pics. See, the skin is got totally excoriated. It's a fistula. So after seeing that pics, what is your understanding? Why it is happening for the patients? Those pics, you have seen the excoriated pics, totally the skin got damaged. Okay, everything has happened. So why it is happening? Very good. The skin got exposed to the content, the fecal material which is coming out from the stoma. Very good. And anything else? Continuous leakage, super ma'am. And proper case, superb. Allergic reaction to the products, excellent. surgical site infections. Excellent. So we address all these like points in our few coming slides. So first, stoma indications. ఎంతమంది పడుకున్నారు ఇప్పుడు? నేను చెప్పుకుంటూ వెళ్ళిపోతాను. So I'll come out from here. Stoma indications. So normally, they'll ask you like how many like days I have to put my bag on my. What is your answer? Condition. But surgeons tell you immediately like after. But some cases they'll avoid to tell the patient because patient will I don't know like under depression and he'll more anxious. Okay, కొంచెం భయపడిపోతాడు. Socially they'll be like avoid all of them. They'll be in the room. So to avoid that, surgeons will never say whether the patient is having like permanent or temporary. But most of the times, you'll see permanent colostomies and temporary colostomies. Temporary means permanent means lifelong. Perfect stoma, a premier surgery. You know this one. The food pathway. Starting from mouth, esophagus, stomach, small intestine, large intestine, rectum, and anus. Remember this slide. I'll ask you a few questions after that. The first one is, second one is, third, the fourth one, and the fifth one. Next time I'll bring chocolates. Then only you'll answer. The next one is nutrition diet. Yes. The next one is pancreas. And the next one is so it's small intestine, the first part of small intestine. The next one is small intestine. Next one is superb. Brother. Next. Now. Okay. So I want to show you something. Pre-operative. Is it important? Likely, like from the morning we are listening about breast cancer and all. Now it's a totally different concept. Okay, pre-operative counseling. Is it important or not? Why it is important? Especially in this like abdominal GI system or the colostomies patients. Prepare them mentally. Yes, good. So prepare them mentally, like reduce their anxiety, result them improve like no complications, or improves confidence, like reduce the hospital stay, and as well as reduce pain and drugs usage. We'll get all these benefits if we give a proper pre-operative counseling to the patient. So as a coloplast, we give pre-operative counseling to the patients. Like we'll explain them what is stoma, ileostomy or colostomy, whether it's permanent or temporary. Okay, and we'll reduce their anxiety also, and we'll like connect them with the previous patients also to get their to get confidence. So they won't ask you much questions after surgery. Okay. So we do counseling as well as we do stoma site marking also. Whenever patient comes to the hospital, if doctors diagnose him, he will undergo for a colostomy or ileostomy. If we get a call, we get some calls from other hospitals, but from Medicover, we have not done any stoma marking yet. We have done our 1 or 2. Okay, we do a stoma site marking for the patients on the abdomen. Whether why it is is it important to do a stoma site marking? Why? Place the bag on the right place to reduce the leakage or any other issues which may patient face in future. So what we do in counseling, history, physical examination, and assessment. Normally, you also do when the patient comes for the OPD. This is the main thing: pre-operative stoma site marking. By doing this site marking, will reduce these problems like leakage, fitting challenges, skin irritations, pain, and psychological and emotional health. So how we do? This is a procedure. So you'll ask the patients to do these exercises like bending, lie down on the bed, sitting position, and stand up. Then we put some marks on the patient's belly, and we'll get a ideal mark. You won't get the ideal mark. This will happen. These are the complications. You put a bag after in the wards or in the ICU. Within 1 hour, it gets leaks because of suture, or because of bending, or because of patient is not supportive. So, few questions to recap. What are the 3 types of stomas? I need hands. Just raise your hands. Apart from Mariana and who are already attended my class, previous classes. Superb. And can you name some pathologies leading to the various types of stoma? It's a common question, it's a general question. In your cancer institute, regularly you will see. Why surgeons will do ileostomies or colostomies? Obstructions and radiation, surgeries, radiation, and are stomas usually temporary? Temporary also there, permanent also there. Can fecal air and urine from a stoma be controlled voluntarily? Right? Can fecal air and urine from a stoma be controlled voluntarily? What is the main issue when having a stoma? So the main issue is leakage. So leakage and skin complications are still the biggest problem of people with the stoma. 77% patients having a leakage issue in a month. Okay, if suppose we take 100 patients, and that 77 patient will say, yeah, I have a problem of leakage. Okay. And so we have some products to show you. It's called Sensora Mio with a body fit technology, which follows entire body movements. Okay, which is more flexible and more elastic. So we have two types of bags now. Okay, I think you have seen one-piece bags in your OT and SIC. Anyone? Seen or not seen? So we have two types of bags system, pouching system. One is one piece and one is two piece. What is one piece? A single bag with a adhesive. Okay. Two piece means adhesive is separate, bag is separate. I'll show you the bags and plates. This is the range which we have, one piece and two piece. We have convex ones. In this picture, you can see urostomy bags here. The outside is different. Outside is different. This is for ileostomy and colostomy, and this is for urostomy. And it's a post-operative bag. I think you have seen this bag. For enema and when the stoma is not functioning, we use this bag for two patients in SIC 2 months back. So you can like physically you can come and you can see the bags and plates here. Now I'll show you how to put a bag for a stoma patients. First, like preparation of skin. For every patient, we give this stoma guide, like stoma measuring like letter, to check the stoma size of the patient. Then mark it on a base so you can cut easily. This one. Now, how many of you like what will you use when you want to clean a peristomal skin or any wound? For a dressing. What will you use for a dressing? Normal saline and betadine. Betadine. Then use hydrogen peroxide. So, but for colostomy patients, use only saline. No betadine, no hydrogen peroxide. And sometimes patient will ask you like whether we can use Dettol or Saffron to clean it. Say no. Okay. And we like Coloplast provide a complete cleanser, which is a like pure coconut oil and a purified water tissue to clean that peristomal skin area. And the second one is complete barrier cream to maintain a pH of skin. So the patient will never face any skin issues. Now Coloplast paste. Anyone seen this before applying a bag? Okay. So this will seal the peristomal area, like with, it will create a gap between stoma and peristomal skin, so it won't leak. Ostomy powder, it's a zinc oxide powder, which will heal the skin cells. Now putting a base, like after we have done cutting, we have put a paste on that plate. Now fixing that one. Now fixing a bag. So we have a like additional mechanism of locking. If the patient is on a like bed, he can't move, but you want to empty a bag. You can't put in a like bag on a straight direction. So you can rotate the bag with a mechanism of locking. We have a locking mechanism with the bag on the bag, so you can rotate the bag and you can remove also whenever you want. This one. Now this it's a diet for the patients who are facing some challenges. Like the patients will say, I'm getting more gas in my bag. So you can say you can avoid these the foods, so it will reduce. Once again, we came to the questions point. On assessment of a patient with a stoma, you note that stoma is located on the right area of the abdomen. Due to its location, this is known as a what type of stoma? True or false? An ileostomy is a surgical opening created to bring the large intestine to the surface of the abdomen. An ileostomy is a surgical opening created to bring the large intestine to the surface of the abdomen. True. It's a ileum. They are providing teaching to the patient with an ileostomy on how to change their pouch draining system. Which statement is incorrect about how to change a pouching system for an ostomy? Which one is the incorrect statement? A, B, C, D. How many are with B? C, B, B, B. Answer is C. When measuring the stoma for a skin barrier placement, be sure the opening of the skin barrier is 2/3 inch large. It is actually 2 mm large. A patient who has a colostomy asks what type of foods they should avoid to decrease the odor gas. You would tell the patient to avoid A, B, C, D. B. Okay. A. A, B, C, D. A. It's onions, alcoholic beverages, eggs, and cabbage. You are providing diet teaching to a patient with an ileostomy. Which food should the patient consume in a very small amount or completely avoid? And please, no Googling. D, okay, and D, and A, B, C, D, D, B, D, and B, B. Corn, popcorn, nuts, and seeds. Patient with an ileostomy are at greater risk of dehydration and an electrolyte imbalance. True or false? False. True. True. Thank you very much. This is our number. I'm Nikhil. That's my number, and I have like CS who is associated with me. He is Mr. Vijay. He'll take care of addressing part and counseling part for the patients. So you can call me or else Vijay. Please note on these two numbers. Anytime you can call us. We'll come and we'll give us stoma site marking and as well as the operative counseling and all. Already, madam have my number, Shishama ma'am, and as well as also is having my number. You can take from her. Thank you very much.
Thank you, Mr. Nikhil, for wonderful interactive and informative session on how to, who needs, how to put on, what to eat, what not to eat, all valuable information you have given us. Thank you so much. Now, no program gets ended up without diet or dietic. Even though it is put at the end of the program, still it weighs the equally as the first topic what we discussed, because without diet nothing works, without proper diet. So which we can learn it from ma'am Srilata ma'am is here. I call upon ma'am to give us a brief talk on dietetics approach towards this breast cancer patients. Please come, ma'am.
Very good evening to one and all. Myself, Srilata. So, for the first time, am I addressing to Moy? Is it? Okay, fine. So, from past 17 years, I've been in the field of nutrition and dietetics. I head the department of nutrition and dietetics. Okay, I have passion for this subject. So, please don't sleep. It is my humble request. So, first of all, you have been listening a lot about cancer since morning. Okay, my PPT is such that you will not be burdened or bored with that, but you try to understand a lot new things about nutrition. You all might be thinking that nutrition is simple, but it is in terms of nutrition, in terms of nutrients, it makes lots of difference. Okay, so we all should understand cancer burden can be reduced or not. Okay, is the burden reduced or is increasing day by day? Because you're working for Cancer Institute. Is it increasing or decreasing? increasing in spite of we having so much of education, awareness, still it is increasing. And as per the WHO statistics, you can see 30 to 50% of cancers can be prevented by avoiding the risk factors. You have got certain avoidable risk factors and certain non-avoidable. That is your genetics, things like that, which you cannot avoid. And your professional hazards, you cannot even avoid, you cannot stop working. So certain things are there which are unavoidable. So they could be the reason. Your lifestyle is one of the reason for your cancer at this moment. Okay. So you can stop tobacco. It could be a smokeless or a smoke. That means your cigars, cigarettes, or your chewing tobacco or your snuffs. The little crush of powder which they inhale through the noses, nostrils in villages, they do it. They take that. Nasham it is called in Telugu. Okay. So those are the leading causes for oral cancers. Whichever is the cancer, early detection is most important. Appropriate treatment and attention for the patient and psychological support is prime. Okay. Now coming to breast cancer, it is the most common cancer among the women worldwide. Till 2020, it was lung cancer, but now it is the breast cancer. Okay. Now let's see if the tumor is over there, you can have a minimal surgery or you can have a complete mastectomy or a total mastectomy. So this is the statistics as per the WHO, which is conducted by International Agency for Research on Cancer. So the breast cancer being top. Okay. This is the statistics of 2020. Before that, it was lung cancer. Okay, followed by different types of cancers. You all should understand, being a female, this is very important to know about this. Okay, so 500,000 women from low and middle income countries died out of breast cancer. Mortality is because of the inequality. Okay, there are barriers to diagnose because it goes undiagnosed because they feel shy to come to the hospital, get for the treatment, or it goes undiagnosed itself. Without the diagnosis, without knowing the cancer itself, the patients are dying. So breast cancer became the most common cancer in the worldwide. Approximately 2.26 million new cases, that is 1 in 10 cancers were diagnosed as breast cancer. So that's become very, very common. Without actions, things will get worsened. That means your proper medical intervention, your surgeries, your radio chemotherapies are really important. Now, this is again with the breast cancer from the World Organization, WHO. 1 in 4 cancer cases, and now it is increasing. Okay, 1 in 6 cancer deaths. Cases diagnosis is different, cases deaths are different. So you can see 1 in 6 is dying out of breast cancer. So it is quite alarming, is it not? So whenever there is cancer or the cancer therapies, malnutrition is set in the patients. Okay, that is because of the cancer or the tumor growing in size using the existing nutrients. Okay, or the therapy, radio, chemo, which will cause mucositis or any other issues. Okay, it could cause nausea, it could cause anorexia, vomitings, or pain, or they may land up with depression. So there could be multiple reasons for cancer and cancer related malnutrition. At times, the absorption of nutrients will get hindered. Okay, with malnutrition, the patient becomes weak, tired, and unable to fight with the infection. Okay, as a result, malnutrition can decrease the patient's quality of life and becomes life threatening. Malnutrition may be worsened if the cancer grows or spreads. It could be local or it could be advanced. Okay, eating right amount of protein and calories is important in healing and in fighting the infections and having enough energy. At times we have malignant ascites. Yes, there's a lot of fluid in the lungs, there's a lot of fluid in the peritoneum. So such patients cannot eat. They keep on coughing, they have pain, anorexia. So as nurse, you should understand their pain and make them comfortable. Anorexia and cachexia. Anorexia is loss of appetite. Cachexia is skin and bones. You can see just the skull over that a thin layer of skin is present. There's a lot of muscle loss, and you can see only the skeleton of a human being. That is called as cachexia. Usually it happens in right heart failure and in cancer. Only these two diseases related to cachexia, or at times in malabsorption syndrome. Okay. So anorexia is the common cause of malnutrition, and cachexia is, again, which I've told, is technically defined over there. So in cancer patients, anorexia and cancer and therapy related cachexia will be there. Okay, okay, okay. And doubts here? With anorexia, because of the cancer, the chemo or radiation or the surgery ill effects, that leads to cachexia. Cancer is eating away the nutrition. Apart from the symptoms, therapy, disease, all concludes to cachexia. Now, a good nutrition is really important. Healthy eating habits during the cancer and post-treatment also it is important. So a registered dietitian is important in a healthcare team. So in India, it is a dietitian, but in abroad, it is mandatory to have a registered dietitian. So cancer and cancer treatment may have good side effects. You know, the most, what you have, deleterious effects of any therapy is your cancer therapy. In any other disease, your treatment may not give you so much of ill effect. Cancer is the only disease which has too many side effects. Okay. So we should have a nutritionist who can sketch a plan and regularly follow up, encourage them psychologically, and whenever they come back, their queries are dealt, and then a fresh plan is given according to the progression. Okay. So breast cancer became the most commonly diagnosed in the world by 2020 and most common cause of death in women, and the fifth most common cause of cancer death overall. Okay, first of all, let food be your medicine and medicine be your food. Who is Hippocrates? Father of medicine. Good nutrition may reduce the incidence of breast cancer and risk of breast cancer progression if they have and reoccurrence. Progression is going deterioration. So you can stop. If the stage 2, it can be stopped with a good nutrition. If they are malnourished, the cancer dominates and the patient may die. Or if surgery and all these supportive therapies have been addressed, still there is a chance of reoccurrence, for which good nutrition will help them to avoid the reoccurrence. So plant-based diet is excellent for cancer. So plenty of fruits and vegetables. It includes high fiber in terms of your beans, legumes, seeds, whole grains. Whole grains are really important. Can anybody tell me whole grains? Whole grains. Yeah, cereals. You can tell it loudly. We'll appreciate you. Cereals and millets like your rice, maize, barley, okay, wheat, all these are your cereals. Your ragi, your bajra, your jowar, foxtail millet, quinoa, all these are your millets. Okay. Inclusion of these whole grain cereals and millets will ensure you getting good amounts of antioxidants which fight against the cancer, which gives you good amounts of protein, good quality of carbohydrates in terms of having a rich fiber, which improves your good bacteria in the intestine. Once your good bacteria increases, your immune system increases. The carcinogens, the toxic compounds present in your intestine will be bind with that fiber and excreted out of the body. If you lack fiber, if you eat more of your carbohydrates like your bondas, what you eat for your breakfast, your bread jams, your Maggies, all your what are donuts, pizza, burgers, they lack fiber. They have toxins, they have chemicals, they have carcinogens. They get lodged into your intestine. Over a period of time, they start proliferation. The cancer develops. But if you eat that nasty junk also once in a while, you eat healthy food that is flushed out of your body. Okay? So include protein in every meal. If you see a cancer patient, every meal they have to have protein. Okay, and especially plant-based, and low to moderate fat to be emphasized. If you think that patient has become very thin and weak, we shall give them more fat. No, that is not at all correct. In my further slides, I will discuss. Limit the processed foods and refined grains, flours, and sugars. That's what I have told you. Plenty of fluids are really important to flush out the toxins of chemotherapy out of the body or the drug therapy. Physically active is very important. Should have an ideal body weight. Obesity, overweight is risk for breast cancer. If you increase your weight by 10% above the age of 18, you will be at risk of obesity. And raise your hands who are BMI is more than 22. You don't need to raise it up physically in your mind. So we all are at risk. 22.9. Okay. It is important to lose weight and maintain a healthy weight with a diet and an exercise. Okay. So as I have discussed, plant-based food are really important. Lifelong commitment of plant-based is advised for reducing the risk of developing breast cancer. Okay. Or if patient is already having breast cancer, it will reduce the reoccurrence. It is a study which is conducted in 91,000 women also. Okay. So 91,000 is a small number. Is it? No, it's a huge number because you guys are sleeping. That's why I told that. Okay. A large cohort study over 91,000 showed that plant-based diet was associated with 15% reduction in breast cancer. 15 people saved from breast cancer. It's not a joke, right? You all work for corporates. You know how much money. Just now, Swati madam was saying that they have spent 10 lakhs 20 years back. 20 years back, 10 lakhs is 1 crore now. Okay. Mediterranean diet, which includes, all your nuts, oil seeds, your fish, fruits, vegetables, that also has proven to be beneficial. So fruits and vegetables, I'm not going to read out because you all are sleeping. So I will be focusing only on few points. Vegetables, fruits are rich in vitamins, minerals, fiber, antioxidants, plant-based nutrients, polyphenols. Okay. If you see a red color, orange color, green color, they will have something called as carotenoid. Sridhar sir is saying who is sleeping. Next, somebody is awake for my class or not is worried. నేను లేపేస్తానులేండి. Oh, good. Okay. Lycopene is found in your peel of your red apple, in your tomatoes, strawberries, and your bell peppers, red color capsicum. Okay. That is really potent antioxidant for cancer. Your indoles are present in your cruciferous family. Cruciferous family, anybody can tell me? Yes, they are pungent vegetables like your cabbage, radish, your broccoli, cauliflower, okay, turnips. All this belongs to cruciferous family. They have indoles which are really, really good, potent antioxidants. And your isoflavones and flavonols, you find them in different vegetables, fruits. Isoflavones, you find them in soya beans. Okay. So always you should consider 7 colors of vegetables and fruits in your diet. You all know Vibjor? Tell me what is Vibjor? Blue binge, sir. Blue, green, yellow, orange, red. Now tell me violet color, vegetable or fruit? Indigo. Berries. Okay. B. Blue. Any sir berries? Brinjal. Munka. Green color. All green vegetables. Most of the vegetables are green in color. All the greens are green in color. Sorry? Bronchus. Bronchus in your lungs, yeah. Broccoli. Hey, don't laugh. She made an attempt to answer. Chalo. Red color vegetable. Okay, tomato. ఏదో వెజిటేబుల్ ఫ్రూట్ చెప్పని ఏదో ఒకటి రెడ్ కలర్ గ్రీన్ బెల్ పెప్పర్స్ అండ్ యాపిల్స్ ఇంకా చెరీస్ ఓ గుడ్ ఓ అట్లీస్ట్ 50% ఆర్ అవేక్ ఐఎమ్ సో హ్యాపీ ఫర్ దట్ ఎందుకు నవ్వుతున్నారు నువ్వే అంత అప్పటిసని వండుకుంటున్నావు అందుకే నవ్వుతున్నావు గట్టిగా సరే సో there's a study that if you consume 25 or more serves of vegetable weekly, okay, weekly if you're consuming, that will reduce 37% of risk for cancer, breast cancer. Okay. So beta carotene again is it is one of the 600 carotenoids. You have beta carotene, cryptoxanthin, lutein, zeaxanthin, xanthin. A different color pigments are present in different colored foods. Okay, you have anthocyanins. Okay, you have these anthocyanins in your what do you call this eggplant, brinjal. You have it in your beetroot. You have it in your blueberries. Okay, these are again potent antioxidants. Purple color pigments or dark blue color one. Okay, so all your green leafy vegetables will have beta carotene. Okay, can you name some green leafy vegetables? Fatafa 10 I want. Done already. ఎన్ని ఫెనుగ్రీక్లమ్మా broccoli is a vegetable. Gongura. Already told gogu. Oh God, your knowledge about greens is really poor, guys. How many of you understand Telugu here? Raise your hands, those who understand Telugu. Okay, fine. So, it is so that if I tell in English, I don't know how far you understand, but you have sorrel leaves, you have basil leaves, you have fenugreek, you have spinach, you have spring onions, right? You have lotus leaf, you have colocasia leaves, you have radish leaves, mint leaves, curry leaves, coriander, right? What else? Amaranthus, ponagani. What else? Only amaranthus has 3,000 varieties. You know this? Amaranthus species itself. All of you have done BIPC, you know. I've done in 94. So it has 3,000 varieties. Imagine. And you people are unable to tell me 10 varieties of leaves. Puppy shame. Okay? Fine. So carotenoids have protective role in different sites. Okay? Many cancers can be prevented with beta carotene because they are antioxidants. Likewise, your vitamin C. Limonene is a bioactive component present in citrus peel. If you all know, we India have a practice of making lemon pickle. We eat the lemon rind all or the peel of the pickle. But in modern days, what do? We just squeeze lemon and say it as a cocktail or a mocktail and we drink and throw the rind. Is it good to take the juice of it or it is good to practice our old tradition of eating the rind or the peel? Both who will say raise your hands? Wrong. It is eat the traditional pickle. If you are non-hypertensive only. If you are hypertensive, no. I don't recommend juice. Squeeze that lemon on your foods. You have your pulihora, you have your poha, on any of your salads, any of your fruits, any of your food items, squeeze the lemon juice. Don't prepare a lemon juice. You are not a cancer patient. The cancer patient is not eating, give them lemon juice. They will feel very refreshing. It alters their mouth because of the drug activity. They have altered taste, the metallic taste. They drink that lemon juice, it is good, but we are not so. Any pregnant lady suffering with morning sickness, give them lemon juice, not we. Okay? We should eat lemon rind as such. If you all can eat, cut it and try eating it raw. Okay? So these pigments are really important. Your alpha carotene, beta carotene, tryptophan, zeaxanthin, lutein, lycopene, okay, which lowers the risk of breast cancer, estrogen related receptor breast cancer, that is. So you have two types. One is progesterone, and the one is estrogen. So the particular type of estrogen related breast cancer will be lowered. Fiber again is really important. The significance of it, I have spoken it earlier. So one most important thing over here I would like to highlight is most of us think that organic food is good. How many of you believe in that? Organic. Amma, raise your hands, please. I will give you 5 and Okay. Organic foods, which are raised without pesticides and all. They claim it as organic food. But please understand, organic foods are very costly. They are threefold costlier than your normal food. And we are not having any clue whether it is raised without the fertilizers. We have no clue because nobody goes to that farm and see. Okay, if at all, if it is stamped by FSSAI, still it has 7 to 8% of fertilizer. Okay, so if it is raised in your kitchen garden, they will have good amounts of polyphenol. They will have good amounts of antioxidants. They can be lowering the risk of cancer. But is it easy to procure them? No. Impossible. If it is possible, try to raise them. Okay, fat again is important. Always a low to moderate fat is good. You cannot take it in excess because it gives you more of calories. Okay, and fats like butter. About what that girl is looking into. Come here, come in front. Butter, full fat dairy, poultry, skinned, fatty meats, hydrogenated oils, and margarine. These are very, very bad fats. They are saturated. And some of them will have trans fats, which are, what do you say, which provokes cancer in the body. So that is why those type of fats should be limited or to be avoided. It is always ideal. Those are fantasy. You know, you just look at them, they are very yummy and tasty. Once they go to the into the body, they cause damage. Once in a while, it should be okay, but I don't even recommend that. Instead, eat olive oil. I don't recommend because it is very costly. Avocado nuts, again, avocado is very costly. You know what is the cost of one avocado fruit? 300, one fruit. Is it necessary? No. So whatever we get locally fresh available, we can get the same thing. Seeds, yes. Nuts, I would recommend. Nuts in the sense you have your almonds, walnuts, pecans, macadamia nuts, pine nuts and all. Seeds are your till seeds. Till seeds you all know? Nuvulu, till, kashkash, poppy seeds, gasagasalu. ठीक है ना? Pumpkin seeds, flax seeds, chia seeds, all these are seeds. Mustards, they have good amounts of essential fatty acids and fatty fishes. How many of you are fishitarians here who eat fish? How many of you eat salmon, mackerel, sardine, tuna, herring? ये तो नाम भी नहीं जानते, है ना? Deep water sea fishes, they are fatty fishes. They will have good source of omega-3 fatty acid. If anybody is pregnant, every week you give them one piece. So the baby's brain development, the retinal development, the immune system builds up very well. Okay. Then limit the animal fat. Most of the people will eat pork, beef, meat. So the lards or the beef variety of fat that should be avoided or limited. Hydrogenated fat is your vanaspati or dalda. Should be strictly avoided. Your biscuits, all your bakery biscuits will have the dalda. So better to avoid. So you can focus on regional available oils like your peanut oil. You can have your till oil, mustard oil, because I've taken it from an abroad site, international site. So it is showing as olive oil. Okay, healthy fats, whichever I have mentioned, try to incorporate. So try to increase the omega-3 fatty acids, which on consumption will convert it into docosahexaenoic acid and icosapentaenoic acid, which is lowering the risk of cancer. You have omega-6 FUFA that will increase the risk for cancer. Okay, your sunflower oil and all. We all try to eat sunflower oil. How many of you eat coconut oil? Mustard oil? Peanut oil? Till oil? Sunflower oil? All will raise your hands. There you are for the risk of cancer. Okay. Soy is excellent source of protein, fiber, B vitamins, iron, and isoflavones. This is the nutrient which I was mentioning in earlier slide. So it has estrogen, phytoestrogen. We all need estrogen, right? All the females, males to some extent, females in a larger extent. That is a hormone which protects us from many, many diseases like the cardiovascular diseases, osteoporosis, your cancer, and all those. Patients who undergo menopause should take soya products. They get phytoestrogens from the soya bean. I'm sorry. Since soy Since soy is rich in calcium, iron, fiber, protein, it is really good for the bone. Okay, there are many studies which supports that. So you get soya milk, you get soya tofu, you get soya flour, you get soya milk, and also you get a defatted soya atta. So there are multiple things, products available in soya form, so you can use them. But certain studies suggest that soy protein powder, soy protein isolate, genistein, and diazine are the products which have not yet studied completely, so hence should be avoided till you have proven studies. Okay, na? Green tea, how many of you say that green tea is good for cancer? Thank you. Green tea good for cancer? Nobody knows. Yes, yes, it's good for cancer. This is a list of things. It has catechins, epicatechins, epicatechin gallate, and gallic acid. Because that is too much for you all, I didn't write it, but when I tell you all, you can understand. So there are so many compounds present in the green tea which will arrest the formation of carcinogens. Okay, so it is ideal to drink green tea, but without honey, without sugar, without jaggery. Again, if you eat too much of sugars, it craves for cancer. Alcohol is a strong risk factor for many cancers. How many of you take alcohol here? Don't say no. Please be honest. పేషెంట్ కాదు స్టాఫ్ అకేషనల్లీ అదే అడుగుతున్నాం. So be careful. Alcohol is a very strong risk factor for cancers, including the breast cancer. So most of you will support, I take a red wine, I take a blue wine, black wine, all these things comes out, right? So here is a statement for those beautiful women and men. Despite the benefits of resveratrol, this is a compound present in red grapes. In the skin and the seeds, this particular compound is present. It's a phytochemical. Okay. Though you may think that this resveratrol has a good significance, but in terms of alcohol, we have no safe recommendation. So hence, this is not advisable for prevention of cancer or for curing of cancer. So there is a big no for the wines or alcohols if you want to avoid the risk of cancer or recurrence of cancer. There's no recommendation. Red wine or any wine, there's no recommendation. Bones are really important. Due to lot of therapies, your bone calcium leaches out, your phosphorus leaches out, your vitamin D deficiency itself will lead to cancer, right? So adequate amounts of calcium is really important, and vitamin D. If you don't have proper vitamin D, your calcium will not get absorbed into the bone. Am I clear? So calcium and vitamin D you should have in right proportion, for which you need to get exposed to sun at least 30 minutes per day from 11 a.m. to 2 p.m. Okay. And you have certain fortification of products like your milk by vitamin D, and seafoods or the dry fishes will give you vitamin D. If the patient is deficit in large amounts, can anybody tell me what is the sufficient amounts of vitamin D? How many of you see OPs here? 30 nanograms per DL is the sufficient. If it is less than that, 29 will be deficit. So if they have single digit of vitamin D, like 5, 6, 2, 3, 4, 7, 9, they have to take injectable, okay, and a booster dose of vitamin D. What is one capsule of vitamin give? 60,000 international units. What is the recommendation per day? Weekly once it is. Okay, weekly once for 8 weeks followed by booster dose. Okay, na? Or if you have it in single digit, what is the therapy, prophylactic therapy? Therapeutic dosage. 5 lakhs international unit. Okay. Okay, na? So this is how. So you have to take good amounts of calcium in terms of milk, dry fishes, in terms of soya products, in terms of green leafy vegetables, and all. Okay. So sugar, limit your concentrated sweets, added sugars, and processed food, sugary beverages, because they provide you more of calories and no nutrients. High intake of sugar can increase the insulin levels as well as encourage weight gain. If you have more insulin like growth factor IGF in a larger concentration, you're prone for cancer. I repeat, if you have more of insulin production, more of IGF production, then it leads to cancer. So limit your sugars. Don't think that I am thin, I can gorge on sugar. There's something internally happening. Metabolism, you have to understand. Don't look at the weight and get carried away. Okay? Natural sugars found in fruit, vegetables, beans, whole grains, dairy, and soya milk are the best source of carbohydrates. Okay? You don't need to restrict them unless there is a severe indication. Okay? So exercise is most important. 4 or more hours per a week also decreases the hormone level and help lowering the risk of cancer. Okay, breast cancer is more or less related to hormonal imbalance. Yes? No? Yes. So nutrition needs in end of life. How many of you see these patients who are palliative and end of life? All are sleeping. I will speak to Mrs. Sheshama madam. The common symptoms are anorexia, xerostomia, dysphagia, nausea and vomiting. They have loss of appetite, dryness of mouth, difficulty in swallowing, and vomiting and nausea. Okay, they have many problems. They may not take solid food. Patient are not eating, push the plate to a side. No. Try to give them liquids, try to give them supplements, try to give them semi-solids. Make patient to understand the nutritional significance and give them an alternative if your dietitian is not around. Otherwise, take our help. Patients often do not feel hungry. They may eat very little food. So next hour, you can give them supplements or some juice or some porridge. Please give them hourly food so their outcome is good, because they shell out lakhs of rupees for us. So little care, yes, we can take. Sips of water, eye steps, mouth care can decrease the thirst in last few days. Good communication. Patient will call and we will be loading syringes. Patient will call, we will be seeing other patients. Patient will call, you won't even bother to listen. Please don't do such things. Please be responsible. Try to understand the pain of a patient. Okay? Always remember, if the patient comes to hospital, you'll get your salary. Right? You all work for salary? Anybody who doesn't work for salary? So please respect the patient's feeling. They should not feel, disheartened, saying that no nurse is attending me. Few patients say that the nurses are really good. They took care of me like my family. How do you feel? It makes no difference. Free sleeping tickets are given for you people. Huh? It is so nice blessing from them, right? If the patient says those nurses are stupid, they never attend me. How is it? Why do you take a curse? You work so hard, 12 hours, 8 hours, 6 hours, right? You serve them from top to bottom. Everything you take care. That care, if you do it very nice way, you get the blessing. Yes. You don't want to take the blessings. So at times in the end of life care, you may have enteral nutrition, you may have parenteral nutrition. It depends. It changes. It can be a decision taken by the critical care consultant or by a dietitian. It depends. Who is efficient, they will take a call. Okay. So the summary of the nutrition for breast cancer diet is eat 8 to 10 serves of colorful vegetables and fruits every day. Okay. And every meal should have good amounts of plant-based protein. Handful of nuts are mandatory. Include nuts and oil seeds in your diet. Chia seeds, flax seeds, pumpkin seeds, all these seeds are really nutritious. Your legumes, your whole grain cereals and millets are excellent for your fiber, protein, and healthy carbs. Avoid refined products, your chocolates, biscuits, your pasta, bread, ice cream, all these say no when you are sick. Okay? Limit the processed meats and that you eat the cured meats, smoked meats, tandoori kebabs, right? 65 Kentuckys. All these are really bad. Once in a while is okay. Okay? Consume herbs and spices daily. They are really nutritious. Masala teas, ginger teas, clove teas, all these mint teas. We don't like it, right? We like chai milk ka chai. Okay? So take at least 1 to 4 cups of green tea. Cup is this one, not as a mug. For taking that 4 mugs, you will be overdoing one. Okay? Drink plenty of liquids, non-caffeinated beverages. You said right, Coke, right? Some other Red Bull, some other fizz, some other thing. When I see in supermarket, people keep on dropping different containers and cans into their push trolley. Please don't buy all those things. Okay? We are safe enough with your tender coconut water, buttermilk, the zira pani, pudina pani, okay, ragi java. All these are excellent. Don't get carried away with those fantasy names. Okay? Always try to be physically active and maintain good health. So look at the last slide. Please save water. Don't run the taps, wasting the water. Water is precious. Save our earth. Don't litter the place. Thank you for your patient listening. And thank you for the opportunity. I know no doubts, but still, if anybody is ready to ask me, I will sit over there. Sir, you can speak.
Thank you, ma'am. Last but not least, whoever is sitting in the last, please come forward. Sir is going to make us do some exercise, I believe. Please come forward. Make a walk. Who with your friends, please. Brothers, you two, who are there at the last? Daniel, I can't see you guys. Two girls are sitting at the end. Three. Someone is waking up now. Renuka. Come, friends, please. Last, not the least, this something very important we are going to learn. Ma'am said, be active, be active. How are we going to be active without moving from one place to another? I call upon Sridhar sir to give us physiotherapy management in breast cancer patients.
Thank you. People. Am I audible to all? Thank you. Please.
I will go briefly. Most of the since morning, everyone has covered most of the points. I will go directly to the exercise part, or before I'll explain little bit thing. Since morning, all of you are seeing, all of you are most of the cases, these after breast cancer cases, what once woman has once they know that they have a cancer, breast cancer, these are the common surgeries we can go through that. That means patient can go through that. Surgical breast biopsy cases, lymph node removals, breast conservative surgery, mastectomy, and breast cancer reconstruction surgery. How you are all know that one? These are the cases we go through this in normal. Okay. Before going to the physiotherapy session, once we have to assess the patient, assess in the means of chest assessment, examination of surgical sites. We have to know the severity of the pain, and any lymph problem is there, lymphedema evolution, and any skin changes. All these are already covered by our doctors. And post of surgery complications. Just we go through this one. Most of the patients will tell you that these are the main problems: post-operative pain and pulmonary breathing problems, lymphedema, swelling in the hands and everything, and shoulder immobility, and weaknesses in the upper extremity also. Some patients will tell you the psychological problems also. And in that one, pain is the main thing. Pain is due to the surgical part pain and neuropathic pain. In this one, pain management is mainly drug therapy, because of with the medicines only we can doctors will tell you that one. And therapeutic wise, we can apply the cold packs and high frequency TENS. That means transcutaneous electrical nerve stimulation. That means in physiotherapy department, we will apply some modalities for that one. In this one, TENS is the most effective to reduce the pain. And next one is the positioning and postural corrections. And with patient is in the bed position or after going home also. Then second one is the pulmonary complications. Pulmonary complications means breathing problems, airway restrictions, and lung expansion problems is there. For this one, we have to correct the main management options are this one. First one is the good chest physio. Patient is within the hospital or after going home also, they have to go after with a good chest physio, and they will remove the secretions. Breathing is very good. Then second one is the incentive spirometry. Third one is regular breathing exercises and postural corrections, postural drainage position. But with the breast cancer surgeries, this is the main ideal position for sitting and lying. One of the most common thing is edema. Lymphedema is there. Sir also told about this one, Ashwin sir. And post-operatively after breast cancer, most of the patients are complaints this one only. You know that this definition: excessive persistent accumulation of extravascular and extracellular fluid and protein collection in the tissue spaces. There is a definition. In this one, classification, lymphedema is 3 grades are there. In grade 1, small pitted-like cells will come in the operated side, then it gradually increases to furthermore, and last one is the more protein accumulation in the interstitial spaces. Management is to compression bandage and decognitive exercise. For compression banding, the see that one in the is low stretch compression bandage is needed for the this once swelling is came, and second one is a mechanical one. Okay, with this one can drain the lymph anything is accumulated in the hands. Yes, it works like a DVT. Before it's work like a DVT pumps only. Then most of the patients with this one has to do the active exercises, non-resistant exercise. That means simple with the hands only. They have to do exercise, no weights and everything. And exercise should be repetitive one. More of ROM exercise, range of motion exercise is to be ideal for this one. And the dynamic exercise, that means sitting in a one position, doing exercise is not at all ideal for that one. Doing the movements and walking along with walking and range of motion exercise is most ideal for decrease the edema, pulmonary, sorry, lymphedema. Here is just some common exercise I will explain to you. Is everyone is ready to do the exercise by yourself? I will tell you this small exercise with this 6 or 7 exercise. No need, ma'am. Nowadays we are not doing post surgery exercise, but for normal patients are most of the nowadays okay. That's a part of yours, man. Before anything is like prevention is not for the exercise part is not much is there. Only nutrition part is there, I think. Just exercise part means yeah, is there. And for this one, these are the 6-7 exercises after for the best surgery. Sorry, best surgery. First one is wand exercise. In patient is in a lying position, give her a one stick and do the exercise part. Are you want to show anyone? Choose the okay. Are you understanding this one with the figure and lift the hand, lift the band over the for your head as so far you can. Use your unaffected arm to help lift the band until you feel the stretch in the affected arm. Just మన hand full గా lift చేయటం అంతే. Next one is elbows in the. You have to keep your elbows like this and do the exercise. Winging exercise. Next one is shoulder blade stretch. What are the shoulder blades? I think you don't know that one. This is the shoulder blade. We have to give the stretch for this one. By in this position only, we have keep your hand like this and do stretching movement forward. Okay, shoulder blade stretch, and the same thing, shoulder blade squeeze. And that means with shoulder blades has to come closer in this position. Shoulder blades has to squeeze. In every exercise, we have to hold it for 5 to 10 seconds and then relax. Repeat for 5 to 7 times or 5 to 10 times. Depends on our time and nine. Next one is side bends. Regularly we can do in the morning time. You have to do. Previous. Okay. Side bend. Next and last one is chest wall stretch. It can be done at the corner of the any room by placing one hand into one wall and another hand to the another wall. Just we have to go forward to the corner. By that one, full stretch will come. All these exercises are nowadays everyone has to do because overhead activities are very less for our generation. అంతకుముందు అయితే మనం అన్ని పైన ఉండేవి తీసుకొని చేసేవాళ్ళు. ఎంతమంది ఇప్పుడు పైకి హ్యాండ్ లిఫ్ట్ చేసి చేస్తున్నారు ఎక్సర్సైజ్? నో వన్ ఈస్ డూయింగ్. ఓవర్ హెడ్ యాక్టివిటీస్ చాలా వరకు తగ్గిపోయింది. దాంతో ఈ ప్రాబ్లమ్స్ అన్ని స్టార్ట్ అవుతున్నాయి. ఓకే, దీస్ ఆర్ ఆల్ ద ఎక్సర్సైజ్ not only for the breast cancer patients, everyone can do. Okay, especially for breast cancer patients, they are having this pectoralis muscles and everything will be in tight position. After that one, already Ashwin sir has told that from the day third we can start from 30 degrees 40. Slowly we can do. After 15 or 20 days, we can reach the full range of motion. Okay. Next one is the shoulder stretch. This one also the same thing. With the wall support, you can slowly lift your both hands to the maximum level. Thank you.
Thank you so much, sir. Really, when we'll do 10 minutes per day exercises, it will give, we will be healthy always in lifelong. Okay, thank you so much, sir. And now I am here to, gratitude is not only the greatest of virtues, but the parent of all others, said by Cicero. First of all, I would like to thank God Almighty to making this program more successful. And on behalf of Medicover Cancer Institute, I am here to extend my gratitude. I would like to thank first of all to our group nursing head and Swati ma'am to give this opportunity, and for she will always encourage us to do such kind of a symposiums and all the kind of this educational practices. Thank you, ma'am. And I would like to thank all our doctors, Dr. Vinod Madhireddy and Rakesh Prabhu sir and Sharat Chandra sir and Naresh sir and Sadvik sir and Yashaswini ma'am and Sridhar sir and Sri Lakshmi ma'am, Sri Lata ma'am. Thank you so much for your valuable words. Valuable words, ma'am. Thank you. And special thanks to our breast cancer survivor who came and shared her testimony with us. Her name is Harsha. And thanks to Coloplast company, Nikhil and his team. And I would like to extend my thanks to all our dancers welcome dance who has done well, and canteen people, Raju, manager, and I would like to thank each and everyone and who decorated this beautifully. Thanks to Daniel and and to and if I have forgotten anyone, please excuse me. And NS ma'am, special thanks to her who always support us. And thank you each and everyone for patiently you are listening from morning till now. Thank you each and everyone who are sitting over here and who are on the online. Thank you each and everyone. Thank you for making this day beautifully.
One more forgotten person to thank, Mr. Hemant. Thank you for from morning. He's patient with us doing all this. Thank you, Hemant.